So thank you, Dr. Prakasa, for your opening remarks. And
Sir, just 1 second. We will play the video.
afterwards, Pooja, we will play the video
Okay.
afterwards. Yeah. So
Okay, sir.
let's give a. So Dr. Naveen sir, good evening to you, and the stage is set for you, and you are the first presenter, and you're going to speak on the treatment decisions based on cytogenetics and molecular studies in AML patients. So over to you, sir, for your presentation, please.
Thank you, Dr. Prakash, for the kind invitation for this really wonderful session that you have organized. I think over 2 days, it's going to be a really comprehensive review of the latest updates, and glad to be able to, to contribute here. So, to kick off the proceedings, I'll be discussing about treatment of AML as per molecular and cytogenetics. And I'll cover also the bigger question about how do we treat AML in 2026 in general, because there has been a lot of movement in the last few years, and whatever we used to do probably might not remain relevant in the future. So, briefly discussing the cytogenetics, molecular, and the risk stratification, and a sort of philosophical question as how do we actually decide treatment when we have a patient in front of us? Like it could be completely different from clinician to clinician, from setting to setting, from patient to patient. So it's not one size fits all. It's rather the era of personalized medicine. And the big competition going on between intensive chemotherapy and the less intense ones trying to prove that they are also equally as good. And briefly, I'll end up with the touching on the what is the algorithm right now, and what is the algorithm that suits everyone, and what is the algorithm that everyone can take home. And this could be different for different people, as I said. So AML is a vastly heterogeneous disorder, and that is one of the reasons why it is a difficult to tame disorder as opposed to many of the other malignancies. So, in terms of cytogenetics as well as in terms of molecular, we have a vast array of abnormalities which are characterized by this disease, and some of them are actually disease defining, and all of them eventually have some or the other effect on the overall prognosis. So, these are helpful not only for designing our initial plan, but it also basically affects which potentially targeted drugs we can use, how the prognosis is going to be there, which patient do we offer a transplant. So a lot of complexities are there and largely determined by the baseline karyotypic and molecular. So these are one of the most important features that we have to take care into. So no, AML, a large proportion of our patients turn out to be AML with a normal karyotype, and that is where the molecular mutations become important. But otherwise, we have these common mutations. You've got RUNX1, RUNX21, PML-RARA, which is APL, KMT2A with various partner genes, and there are higher risk abnormalities like chromosome 7, chromosome 5 abnormalities. And if we integrate the molecular as well, then what we have here, it's a slightly busy slide, but as we can see, a lot of overlap can be there. So even in the basic categories, we may see that there can be coexisting mutations, and most of these mutations are never alone, seldom alone. They are often coexisting with other mutations, and they can have various implications. To just cite a single example, FLT3 along with the PML-RARA would probably carry absolutely no significance, but FLT3 in any other setting would completely alter the line of management. So it depends on the whole constellation of cytogenetic and molecular features that will help us ultimately deciding what we want to do. NPM mutant AML is a very significant bulk. It's almost a third of the cases. And these are also associated with many other mutations. The NPM with FLT3 is a relatively common one. Complex and monosomal karyotypes often seen in association with mutation or loss of TP53. And in the other mutations, we have ASXL1, we've got KIT, we've got the RAS family. These are the ones which play a very important role in the prognostication. So risk stratification is no longer a homogeneous thing. It used to be homogeneous, but it's no longer homogeneous. Risk stratification depends on the treatment that we are doing. So if we are trying to treat a patient with intensive regimens, then what you often follow is the ELN 2022 risk stratification, which I think all of us are familiar with. We've got favorable, intermediate, and adverse risk groups. These are they've remained largely the same with minor modifications over quite a number of years. But what we have right now, the new kid on the block, so to say, is the 2024 ELN classification for patients with treatment with less intensive regimens. So here, adverse is mutated TP53, intermediate is FLT3 ITD, NRAS or KRAS, and almost everything else would fall into favorable. With the caveat, particularly with IDH1, that it is favorable only when treated with an IDH inhibitor. So, hypomethylating agent with an IDH inhibitor would make it favorable. Otherwise, it's not that clearly defined. So, this is the risk stratification that we have to use when we are treating the patient with less intensive regimens. And this becomes more and more important because I think in the current era, age is not the only determining factor. Even for, so to say, younger and fitter patients, hypomethylating agents with venetoclax or with any other targeted agent is somewhat gaining preference in the treatment regimen. So how do we actually decide how to make a treatment? So if you ask very, very old classical way of defining it would be whether the patient is eligible for intensive chemotherapy or not eligible. And that used to divide patients into two groups, one where you would be thinking of curative treatment, the other where we are thinking of palliative treatment in really old patients. In here, age, comorbidities, presence of infections, availability of resources, availability of expertise, all of these become important when we are dealing with this. But now in the era of rapidly available and easily accessible molecular workup, then it could be targetable versus non-targetable. It could be unfavorable risk versus all of the others. And that may help us decide whether we give a hypomethylating agent plus combination or we give an intensive chemotherapy. And access and turnaround time become really important here. If we have to take a decision based on the molecular profile, then it is prudent to not delay the decision. We will have to take the decision in the initial stages of the evaluation. So we would need a quick access to molecular results, which would help us define the treatment. Also, these patients can present with a huge bulk of disease. An urgent need of cytoreduction might be there, which might often tilt us towards the direction of chemotherapy as opposed to targetable agents. But again, this is again variable. A lot of people might prefer to use low-dose cytarabine here for urgent cytoreduction and then maybe combine it with any other targeted drug. So all the options are now available to us and they are open. And it has actually made the decision making a little difficult, maybe not that straightforward as it used to be, but definitely the prognosis has improved. So we have a long list of non-chemotherapeutic options. So we've got FLT3 inhibitors, BCL2 inhibitors. These have been around for quite some time. IDH1, IDH2 inhibitors, menin inhibitors with really, really fascinating results. Hypomethylating agents. We've got injectable oral decitabine plus cedarosidine, completely oral hypomethylating agent. Again, we have had a recent publication for its use in older adults. So these are the non-chemotherapeutic options that we have with us today, and the availability of the drugs ultimately drive what we are going to do. So, are we in the era where we are going to see the fall of 3+7 after ruling for almost 4 decades? And is this the era where we have the rise of HMA plus combinations? So, if we are thinking of a chemotherapy backbone, the most frequently used is 3+7 for secondary AMLs and older adult CPX 351. We have good data favoring flag and cladribine based inductions, but again, the toxicity has to be kept in mind. Slightly less intensive would be Ven plus HMA, and CLAG-LDAC Ven is also a promising option if you look at the recent publications coming from MD Anderson. And we have this huge list of small molecule inhibitors that we can use in combination. So FLT3 inhibitors, majority of the data is in combination with intensive chemotherapy, but we are combining with HMA also. And we have HMA with IDH1 and 2 inhibitors, and we have menin inhibitors also coming in a big way. So This I've taken. This is interesting. I've taken it from a paper which was published only 7 days ago. But what we have to see is here. What I would highlight is we had two authors in this paper, and one from Mayo Clinic and one from Emily Anderson. And if you see here, the guidelines state preferred by Mayo Clinic and preferred by MD Anderson. So even the two big centers in the US, they are not exactly defining a single regimen of their preference. They are rather saying it could be, either this or this. And this is, I think, true for each and every center and each and every clinician, depending on the setup, depending on the resources, depending on the patient's clinical condition, depending on the molecular. I think we have all of these options available to us, and the treatment planning has to be individualized and it should not be like a rigid bracket. What it used to be once upon a time that AML, you start 3+7, but I don't think we are there. We have crossed that era. Intensive induction would still have a role to play in majority of these classes. Core binding factor, yes, the favorable ones, NPM1 mutated, SEPA-BZ mutated. These are the favorable ones which we potentially can cure with chemotherapy. It merits a consideration, definitely. IDH1, IDH2 inhibitors, yes, you do have the option of targeted treatment here. FLT3, again, we have a targeted agent which we use in combination with chemotherapy. These are the groups where transplant would be considered. FLT3, TP53, KMT2A. In all of these, if the response is good, MRD is negative, then probably we would consolidate with chemo-based regimens only. NPM1 mutated, again, if it is FLT3 positive, then in combination with midostaurin, FLT3 would also merit a consideration for a transplant. But if the patient is wild type NPM, then again, chemotherapy alone should be sufficient. These patients should do well. And these patients, you also have the option of using CLIA with quizartinib or gilteritinib in the later lines. So to summarize, now we are in an era of AML where we have a basket full of options. The access and availability of molecular tests has also gone up. So now the treatment, more than the fitness or the eligibility for intensive chemotherapy, I think the molecular test would drive the decision that we are going to take. And chemotherapy still remains the most accessible, and obviously everyone has the most experience with chemotherapy. It has like a decades worth of experience. So wherever we know it works, it actually does work, and it is not something to be jettisoned so easily. But HMA-based combinations have this advantage of less toxicity. Induction mortality is a big issue for our patients in terms of infections and all of those things. So chemotherapy becomes slightly less favored in that setting. Maybe HMA-based combinations would be the right way, would replace these chemotherapeutic agents. We don't have conclusive data to state that they are more efficacious. There may be a comparable efficacy in terms of depth of response. So that is again something that we need to see going forward before we completely say that the era of chemotherapy is over. It's not yet over. It still has its use. But we have to remember that one size does not fit all, and it is the era of personalized medicine. And it's going to only increase from here on, and that is going to be the way forward. I thank you for your time and attention. Thank you.
Thank you, Naveen. It was a very beautiful talk, and you have summarized both old and new. You beautifully highlighted the things that nowadays the old ELN 2022 is we are not following them. So thank you for your talk. So any questions from the experts? Anything?
Naveen, nice talk.
Hmm.
So I have a question. If there is a fit patient with standard risk and you are fearing about the infection, though he is not unfit in that sense, will you give 7+3 or will you give venetoclax and ISA, and this is the induction, and then give 3 doses of cytosine? What is your practice? Fit
So,
standard risk patient, young male.
So it's an interesting point that you have raised, because I have followed this exact same thing in the last two NPM mutated patients, age around 40-ish, not too unfit, I would say, but again in a state where there was a lung infection, not too bad, but I was like, let's go for HMA. When brought the patient into remission, the infection got under check and consolidated with 3 cycles of cytarabine with NBM PCR based monitoring, and both patients are doing fine. So maybe this is a question that is often raised against HMA when probably the depth of response might not be as good as 3+7 in the chemosensitive groups. But there is no reason to suggest that a patient with a morphologic CR with a molecular MRD negative would behave differently if, like, depending on the regimen used to get to that point. I think if a patient has reached a point of a good clinical and in-depth response, whichever way we reach that point, I think both routes are valid. And with HMA, when definitely the induction mortality is practically nothing. So the fear of induction mortality, complications, and the associated expenditure of resources, I think, is somewhat driving me personally away from 3+7 wherever I can go for HMA when I think that's something that I'm doing more and more frequently in the last few years.
So,
And Naveen, there is a data on depth of remission. That standard risk MRD levels versus TP53 MRD levels. We currently have only one MRD level. We don't have multiple MRD levels for the for the high risk diseases. Is there any information on that?
With regards to the high risk groups, the sensitivity of chemotherapy, anyways, in those groups is not that great. So, if we are, say, if a patient is P53 mutated, I'm eventually thinking that I should go for a transplant. Maybe chemotherapy might not be the best option in that case. Even if the patient doesn't become MRD negative with HMA-VEN, I would not say that that was probably inadequate. I would probably say that that is a disease biology which rendered the patient to be, having a disease positive or MRD positive at the end of it. And ultimately, it is the consolidation that is going to, like, bring it down. So maybe we are being a bit too harsh in judging HMA-VEN in that sense. But since we don't have a head-to-head direct comparison in this setting, I don't think it would be too easy to say that chemotherapy has absolutely no role, because it has been around for all these years. It has served us well. But the final answer would ultimately come from a head-to-head. Like, we let the two heavyweights fight it out in the ring and see who wins. I think that is going to be the way forward.
I just had
Prakash, do
one
you have-
question, sir. I just had
Yeah,
one
sure.
question.
Please go ahead.
Hi, sir.
Hello,
So Dr.
Bharat. Good
Bharat,
to see
hi.
you.
Good to see you too, sir. So I'm learning from you only from many years. So just one question: do you have any experience regarding flag ven or flag ida ven as an induction? I've seen some of the centers in Delhi are choosing that as an induction therapy for a few patients, and they have published some data also that patients are doing better with flag ven as compared to 7+3. So, any comment on these practices?
So it's not something that I've personally used, but when we look at the data of flag item win, and I think RGCI has published a paper on that, the response rates are marvelous. It has to be said. It is something that in a resource constrained setup, it would be challenging to deliver it in the way that maybe you guys are delivering it over there. So that is one thing. Again, as I said, when we are saying all, like a single size doesn't fit all, it is not just for the patient, also it is also for the treating center and the treating clinician, like what sort of a resource setup he's working in. So in the resource setup that I am working in, where we have a lot of patients from the empanelment or the Mayojna or the government schemes, I do not have access to flag item in any case. And the patient profile, the extensive use of maybe transfusions, antifungals, all of that is somewhat difficult to manage. So that is an area where I think from center to center it will vary. Also, I think some centers do get really good at doing one thing again and again. You do it repeatedly, you get good at it, your staff is used to it, your residents are used to it. You become really good at delivering that protocol and delivering results with that protocol. But blindly copying it at another center might lead to completely different results. I had a chat
yes,
with a colleague from Southern India who said that cladribine, low-dose Ara-C, and venetoclax is now rising up the ladder, and people are like completely abandoning 3+7 and even flag ida. And clad LDAC and VEN is becoming more preferred, even above HMA VEN, wherever the patient is like of borderline fitness. So again, I think it depends on the center's experience and the availability of resources, the comfort of the treating center and the physician with it, and also the patient's condition. So I think all of that combined would help you make the right decision. I don't think in the era of AML that we are living right now, there are any clear rights and wrongs. I think it's much more open.
yes, yes, it's right.
True,
And
sir.
I think we will be having a lot of questions regarding this. And so our next session and speaker can do Just a second for the next
So
question.
there
So
is a
thank you,
1
Dr.
minute.
Naveen. And we need to stick to time. Yes, Ekta, you can go ahead.
So yeah. So Pooja, can we start the video? 1 minute
Now
video.
we will be sharing a 1 minute video of our academic partner, MicroCRISPR.
Sure, sure, sure.
Every day, millions of cells move through the human body. Most perform their role flawlessly. Some protect, some repair, and some defend. And among them are T cells, the guardians of our immune system. Is simple: to identify what doesn't belong and eliminate it. But cancer is different. Cancer has challenged treatment for decades. What if the answer lies within the patient? This is therapy. The process begins with the patient's own T cells. These cells are and engineered with a new capability, a specialized receptor that enables them to recognize specific cancer targets. Once transformed, they are expanded into millions of CAR T cells, prepared for a singular purpose: to seek out cancer cells wherever they may be. They engage cancer cells and trigger their destruction. As they continue to expand, more CAR T cells are generated, reinforcing the immune response and strengthening the attack against cancer. Built from lipids, powered by the immune system, CAR T cell therapy is redefining the future of cancer care.
So thank you, Pooja. This was MicroCRISPR from Medin. And for our next talk, I would like to invite my dear friend, Dr. Aryan. Dr. Aryan Jain is Associate Professor Clinical Hematology at prestigious PGI Chandigarh, and he is moderating a session on AML from India Updates. And Dr. Aryan, now you can invite your panelists and take over.
Hello, thank you, Dr. Shikawat, for this invite. So I would request so are my slides visible?
Yes, they are visible.
Yes, sir.
Yeah, thank you. So Dr. Naveen has already set the stage, and we have kind of talked about what are the options with us and how the field is going. With this, I would like to invite my panelists, Dr. Devesh Parashar from Jaipur, Dr. Bharat from Gurugram, and Dr. Aishwarya Raj from Ahmedabad. So hello and welcome you all. So
good evening, Aryant. I'm here only.
Yeah, good evening.
पीछे से हट जाओ, उनको वीडियो भी ऑन.
So I'll request other people to maybe mute except the panelists and the organizers. So let's start with a case scenario.
So sorry to interrupt. Just make it full screen.
Yeah, just yeah. So
Yes,
is that yeah? 49-year-old female, background history of Crohn's disease, was on steroids, azathioprine, mesalamine. Crohn's disease is stable now, has presented with anemia, smear showing 85% blast, AML FLT3 TKD positive, cytogenetically normal, no other abnormalities detected on NGS. admitted for further therapies, reasonable organ dysfunction, PS 0 to 1. So maybe we can just one word answer preferred induction strategy from all the three panelists. Maybe Dr. Devesh, you can go first.
Yes, Naveen. Yes, Arihant. I will start this patient on 3+7 actually, according to the fitness of the patient. Patient is fit. There, she has no no organ dysfunction. We'll start her on 3+7 chemotherapy.
With FLT3 inhibitor or without FLT3 inhibitor?
The patient is FLT3 inhibitor. I will wait. The patient is already has that report FLT3. Then we'll start midostaurin. I will add midostaurin after that also. One day for 2 weeks after day 8 actually. Day 8 to 21. Yeah.
Yeah. So ratify approach, Dr. Aishwarya.
So 49 years of age with a previous history of Crohn's, like, and patient has been continuously on steroids. So maybe I would I would be a bit more cautious. So definitely a FLT3 inhibitor, but with maybe Azaven, I would try to play safe.
So HMA when FLT3 inhibitor. Dr. Bharat, I can't see.
I will also start with HMA plus when and see how she responds after one cycle, then plan accordingly.
Yeah. So house is kind of divided, and there's a reason why it is divided, which we will talk about because of the recent updates. In fact, this was our patient. We also started with HMA when she did not attain a remission in cycle 1. In the cycle 2, we added midostaurin. She still did not attain a remission. Then we gave her gilteritinib, got a remission, and finally she was transplanted. So basically, we all probably agree that when HMA is the standard of care in elderly unfit patients, and the CR/CRI rates are 66%, the median OS is 14.7 months. However, even in these elderly unfit patients, the curves continue to drop, which is telling us that actually just HMA when continuous is essentially a non-curative therapy, and ultimately it is how we consolidate will finally define how our patients survive in future. So the debate between in adult above 60 or above 65, I think more or less the debate is settled more so for the Indian context that it has to be HMA when. The more problem is in young fit patients. So we have two recent trials to kind of answer that question. This was first a Chinese trial somewhere came in Blood in June 25, where Vendeq was compared head to head with idarubicin, cytarabine, and in a young fit population, both the cohorts were finally consolidated with a cytarabine based IDAC based approach for 3 cycles. And these are the results that for most of the subsets, except for A20 core binding factor AML, where the chemotherapy backbone was superior, for most other results, they were either similar, or the HMA when was, or the when deck was scoring over the intensive chemotherapy arm. And if we looked at the EFS and the overall survival, they are absolutely overlapping. So probably telling us that both the approaches are probably similar, and a Vendeq approach would be probably superior. So the only one subset where besides 821 where Vendeq was clearly superior was age more than 40 years, adverse risk, epigenetic mutations. These were the ones where Vendeq is favorable, and core binding factor AML, that it was a major difference, 44% versus 88% in the CR rates. So in that subset, probably we still have to go with intensive chemotherapy. Yeah. So this is a large meta-analysis which was recently published again in younger acute AML patients, not a head-to-head data, but rather a culmination of a lot of Western centers. Again, they said that the pooled 1-year OS and CR rate exceeded their conventional SEER database of intensive chemotherapy, which was 75% with HMA-VEN versus 62% with the conventional chemotherapy backbone. Then came this paradigm trial, which was the ASH plenary, much talked about head-to-head American multi-center trial, phase 2 actually, not phase 3. Primary endpoint was EFS and not overall survival. And they had excluded these three categories: age less than 60 years, patient having NPM mutations, core binding factor AML, and FLT3 AML. So when after excluding these categories, for most of the other categories, actually the AZA-VEN scored over intensive chemotherapy, the overall response rate, CR rate, ICU admission rate, hospital admission days, EFS, for all these other subsets, actually HMA-VEN was superior to intensive chemotherapy. And this, by the way, was AZA-VEN continuous versus intensive chemotherapy followed by IDAC. So, however, where we cannot universally apply HMA-VEN in a young fit patient, those would actually be coming from the limitations of paradigm trial, which say that CBFML, FLT3-AML, and NPM mutated AML with age less than 60 years, maybe we need to be a bit more cautious before universally accepting HMA-VEN, and here we need more data. Other limitations of the trial are this is actually not a very big trial. It is a phase 2 trial, not a phase 3 trial, only 86 patients. And even in that, almost 40% of the patients were actually getting CPX351, which is not something most of the world practices currently. This is more data coming from ASH this year. So Asco 2026, just June, where a long-term retrospective comparison again telling that probably the induction strategies do not matter that much, and survival is primarily being driven by the molecular risk profile and transplant and not the induction strategy. So probably FLT3, still the jury is yet, the final word is yet to be played, but in FAB M5 morphology, again, monocytic HMA-VEN does not do as well, while in core binding factor AML, the intensive chemotherapy still scores over. This is why this is so, is because in real world, the HMA-VEN is not something which is easy to deliver. The median time on HMA-VEN in the real world cohort, at least in the older unfit patients, is not more than 7 to 8 months. So coming with this background in mind, the next question and understanding that most of us are increasingly adopting to HMA-VEN, I would also like to ask my panel members the next question. When you are using HMA-VEN, what is the duration of venetoclax you are using for the initial 2 cycles in your induction regimen? Maybe Dr. Devesh, followed by Dr. Aishwarya, and finally Dr. Bharat.
Arihant, we are giving usually 3 weeks. Actually, it depends on the patient, actually, in the condition of the patient, but we try to give at least 3 weeks actually. So in sometime it is 2 weeks to we continue to 2 weeks. If the patient is very sick, then we'll stop the VEN due to neutropenia. But we usually try to give at least 3 weeks, and we use posaconazole for fungal prophylaxis in our setting. And the cost of the VEN is also is important issue. So we give usually 100 mg venetoclax along with posaconazole prophylaxis. We usually give starting first 2 cycles actually at least. So we use 100 mg along with posaconazole prophylaxis.
So just kind of, I'm sure you all must be aware as well. So with posaconazole, actually the recommended dose of venetoclax is they say that 50 and 70 mg are sufficient, and we have we also published our data showing that 400 was equivalent to 50. That is one, but the why we were pushed to use when 100 was because 50 milligram, the company was not easy to provide most of us. But now with the generic, when already in the markets with a very reasonable price, maybe again that situation is also getting answered. So Dr. Aishwarya, so 21 days when with posaconazole is probably what most centers practice. What is your strategy in induction cycles?
So I usually like it young. If we are talking of young fit patients, then it's 21 days, and I have been able to give it even for 28 days for one of my patients. But the elder ones, obviously, there where transplant and all is not in the plan. So there it's like 7 to 14 days, which depends upon how the patient is tolerating it, because I'm in no hurry to bring the patient in CR in 1 or 2 cycles, because I need to continue the same therapy anyways for that patient.
Yeah, Dr. Bharat.
So regarding the HMA and VEN combination, one more point that I would like to highlight that when we say to the patient that we are going to start him on less intensive therapy with some tablets, so it is well accepted by the patient also, and they are more prepared for it when we give them the option of HMA plus VEN. And now regarding the dose of venetoclax, we generally go for 28 days complete venetoclax, unless he's having some sepsis and all. But sometimes some centers go for bone marrow test after 2 weeks and 4 weeks just to see what the cellularity of the bone marrow is. But sometimes it becomes difficult for us to convince patients that we need one more bone marrow test within 14 days. So we go with the CBC reports, and we generally don't stop the venetoclax at 14 or 21 days. We go for full 28 days and then see with the bone marrow test whether the marrow is cellular or not. Then we decide the subsequent cycles whether we need to reduce the dose or we need to add something else to the combination of the treatment.
Yeah. So
Sir,
28 days without a posaconazole, maybe also with 400 mg is also that. In fact, that's the standard strategy. But with posaconazole, probably I think 21. So our practice is to give it for 21 days with posaconazole and then do a check marrow somewhere between 21 to 28 days. If we are
I would
using
request you to conclude your panel discussion in a minute or two. Thank you.
Okay. So our practice is to kind of with the triplet we would always do till 14 days and then finally do a check marrow. So I guess so that the two takeaway also which I would like to they have blocked my slides, but by the two takeaways I would like the listeners to go through is the Opti AML trial, which kind of compared 14 days venetoclax head to head with 28 days venetoclax, which was the EHA update. And in that, it was a non-inferiority trial, and they kind of told that 14 days is not comparable to 28 days, and it failed the non-inferiority margin. So the dose intensity is important in first 2 induction cycles. The second major update with respect to FLT3 AML was the PASHA trial, which kind of compared head-to-head 7+3 midostaurin with 7+3 gilteritinib, and actually the trial failed to meet its primary endpoint, probably telling that 7+3 with midostaurin, which is way more cost effective, is comparable to 7+3 with gilteritinib. So with that, I would like to conclude my session. And I would like to thank all my panelists as well as Dr. Shekhawat for organizing this and allowing us to interact with each other. Thank you.
Thank you. Thank you, everyone. This was good, very beautiful. And dear team, if there is anything like this, with the slide not moving, please look into this. I understand that there is shortage of time, but some of the slides, if they are hanging, they are very important. And
Sure, sir.
thank you, Aryan.
Yeah,
It should not be
thank
like
you.
that it is hanging. Yeah. So thank you, Aryan,
Yeah.
and thank you, all the panelists.
Thank
So,
you. Thank
for
you.
our, yes, sir. Our next session,
Thank
I'd
you,
like
Aryan.
to,
It's a good.
Dr. Devesh, you need to continue, boss. Huh? You don't leave. So, Devesh Parasar boss will be speaking on our next session. It's a practical consideration for management of intensive chemo and eligible AML patients. It's a sponsored session by FB. So, over to you, Parasar boss.
Yes, thank you, Dr. Prakash. Thank
Dr.
you for giving
Arihan,
me
sir,
the
you have
opportunity.
to like stop share your screen. Kindly. Tech team, yeah. Yes, sir. Go ahead.
So,
Boss,
so
we are
the
running
slides
slightly
are
late.
as
Yeah.
such. Yes, yes. Kindly, please allow me to share my slides. Yes.
Yes, sir, you can share, please.
Yeah. So, yeah, and my slides are visible. So it starts
Yes, sir,
from
visible.
take
Sir,
home
make it full
message.
screen.
Yeah. I'm doing this. Yes. So thank you, Dr. Prakash, for having me. I will try to finish it on time. And already Dr. Naveen and Dr. Arihant had discussed the AML treatment, the new advancement, EHA in AML treatment. I will be talking about this few Asco EHA meeting regarding AML as I when. So as we know, AML is an aggressive disease and it leads to poor outcome in patients. We have a target L2 and we will be talking about this thing. So these are the things we know already. So the incidence of AML 4 point, these are US data 4.3 in 1 lakh patient. Median age, the usually patient present between 65, more than half of the patient are more than 65 year of the age. 66% intensive chemotherapy receive intensive chemotherapy, and these are few risk factors for AML patient. The 50% patient, more than 50% are 65 year of the age patient. Male patients are 1.5 times more. Smoking associated with 50% risk. Overall leukemia risk. Some genetic syndromes are associated with, and some like syndromes like MP and MDS are associated with AML, and benzene formaldehyde also associated. It usually presents with symptoms to anemia, neutropenia, and thrombocytopenia, like fever, anemic symptoms, shortness of breath, or bleeding manifestations, some organomegaly or bone pain. So the diagnosis of AML is like morphological analysis followed by immunophenotyping with cytogenetics and followed by molecular testing. That is very important part of AML diagnosis and to risk stratify this disease. So these are the basic workup for leukemia. So AML, we have the strategy like young and fit patient. We usually give high intensity chemotherapy and consolidate the patient. If the patient is adverse risk, they consolidate the patient with transplant. And if patient is non-adverse risk, then consolidate the patient with the high chemotherapy. And older or unfit patient, we have low intensive chemotherapy. The target is to induce remission and control the disease and maintain the remission and prolong the OS. So uh, the Ferreira criteria to define unfitness for intensive chemo in AML patient, if the age is more than 75 years, the patient has some heart disease like CHF or EF is less than 50%, some documented pulmonary disease with DLCO and FEV less than 65%, or any pleural neoplasm is CKD on dialysis, liver cirrhosis, or liver disease, some active infections, and the performance score is 3 or more than 3, that is not related to leukemia. So these are the
mainly the age and the frailty are the prime predictors of outcome in AML. These are the basic complete remission definitions, a complete remission with MRD, without MRD, with incomplete or partial remission. So historical efficacy of intensive or less intensive chemotherapy, the intensive induction chemotherapy, we have cytarabine 100 mg per meter square for 7 days continuous infusion, or daunorubicin 90 mg per meter square. The complete remission rates are 70% with 200 mg cytarabine, and daunorubicin 90 mg per meter square, 64%. But the usually most common used regimen that has a complete remission rate of 75%, and that is well tolerated. It has the same or more efficacy than daunorubicin 90 mg. That is, we are using 100 mg per meter square for 7 days, with daunorubicin 60 mg per meter square for 3 days. And the other low intensity chemo regimen, we have decitabine, azacitidine, or low dose Ara-C. And these are CR rates of less than 20, the highest approximately 20 with azacitidine. So the patient who are eligible for intensive chemo have relatively high rates of complete remission. However, the patient who are considered ineligible for high intensive chemotherapy have much lower complete remission rates. So if bone marrow transplant has been done of these patients, the outcomes based on the age, stage, time from the diagnosis, comorbidities, and performance status, along with the histocompatibility, the donor, recipient, transplant. In the conditioning regimen, the immunosuppression has been used. So if the chemo plus SCT has the highest ones or highest survival, whereas no chemo or supportive care has lowest survival, as we know. So recommended therapy for AML patient is fit for intensive chemo. If the if the FLT3 mutated patient, 3 plus 7 chemo plus some FLT3 inhibitor, consolidate with IDEC, with midostaurin, and maintenance with midostaurin. Non-FLT3, 3 plus 7 with consolidation followed by oral AZA. And the patient has a therapy related or myelodysplasia related AML, the treatment induction is CPX 351 with consolidation, and the patient is not suitable for intensive chemo. We have the things like AZA, decitabine plus venetoclax, or LDEC plus ven, or the best supportive care. If we have IDH mutation, then we have ivosidenib plus minus AZA. So the treatment evolution of AML, it is static since 2000. Approximately 40-50 years, the treatment is same. Like in the introduction of the chemotherapy in 1960, followed by first bone marrow transplant in early 70s with cytarabine introduction, followed by idarubis in early 2000. Then after 8 to 10 years, there is azacitidine for less than 30% blast, 20 to 30% blast introduced, followed by decitabine, and then azacitidine is approved for in 2015 for more than 30% blast. And after that, the paradigm shift towards the targeted therapy like midostaurin came in the game, gilteritinib, and the venetoclax came in the game. And now the ivosidenib and menin inhibitors as now. Naveen already told all these things regarding all these things in previous on that lecture. So the venetoclax is a BCL2 inhibitor. It attach to BCL2 and it leads to apoptosis of the cancer cell. So this is Wiley trial. This is my treatment. If patients are taken, the total number is for 30 approximately. There are two arms, venetoclax plus azacitidine, and other one is the azacitidine plus placebo. The dose, the primary endpoint are overall survival and composite CR, and the other secondary points are these are overall survival with composite CR with, according to mutational groups and transfusion independence. And the dose is like dose ramp up is like 100 mg, 200 mg, 400 mg, and the until these therapies until disease progression and acceptable toxicity or withdrawal of consent. These are the inclusion or exclusion criteria. The inclusion criteria are previously untreated AML with intensive chemo ineligible patient, And the exclusion criteria as the patient who are favorable risk cytogenetics like translocation 821 inverse 16 and these are the baseline characteristics of these patient. The median follow-up time of 43.2 months. The patient who are on Ven plus EZA, the median OS 14.7, approximately 15 month, while the patient who is on azacitidine plus placebo, the median OS is 9.6 month. The composite CR rate is 66% in EZA plus Van arm, whereas 28% in EZA arm, and the CR rate is 37% versus 18%. That is almost double in the Van plus EZA arm. So Van plus EZA had more than tripled composite CR plus MRD response rate, that is 23.4% versus alone EZA arm is only 7.6, approximately 8%. So this is the analysis of time to respond to Van plus EZA per cycle. Approximately 65% of patient achieve CR in one cycle, 75% achieve after 2 cycles, and you can say approximately 93% achieve after 4 cycles. We call it like EZA plus Van failure when the patient does not achieve CRI after 6 cycles. There is a no the patient who achieve later response later derive a similar clinical benefit from venetoclax combination regimen. Those achieve early responses. So this is post hoc analysis of Wiley. There's the same slide, like 65% achieve CR after 65% after 1 cycle, 75% and 93% after 4th or 5th cycle. So the venetoclax dose modifications with moderate CYP3 inhibitors, the reduced venetoclax by 50%, and with like a strong CYP3A inhibitors, the dose is 100 mg or less. Posaconazole, voriconazole, we have to reduce the dose. The 50 to 70 mg is sufficient. And so this is the median number of treatment cycles in age more than 75 years. Van plus EZA median dosing rate is 21 days, and the duration is 34. This is an intention to treat population. The 43.2 months follow-up intention to follow-up data is this. These are the patient who receives CYP3 inhibitors. These are the prophylaxis the patients are receiving. EHA and ECL guidelines are we have to give a prophylaxis, fungal prophylaxis in the patient according to the individual context of the patient medical history. The patient have a low certainty of evidence treated with Van EZA. It is conditional, but in India we are giving everyone to initial 2 cycles fungal prophylaxis. So the bone marrow evaluation to assess the remission, the setting of grade 4 cytopenia, and while A remission defined less than 5% blast, MLSF grade 4 cytopenia following cycle 1. So cytopenia management recommendation are the before achieving remission, if there is grade 4 neutropenia or thrombocytopenia, do not interrupt venetoclax, and if you have go for the bone marrow examination. If you have suspicion the patient is not achieving, then to continue the venetoclax, and if after achieving remission, first occurrence of grade 4 neutropenia or thrombocytopenia that lasts for more than 7 days, then we can delay the subsequent cycle and use the GCSF, and we restart at the same dose our resolution of the neutropenia thrombocytopenia to grade 1 or 2. And if there is subsequent occurrence of grade 4 neutropenia thrombocytopenia that lasts for more than 7 days, then delay subsequent cycle or monitor blood count and use the GCSF. And we can
Sir,
reduce the
sorry.
venetoclax by 7
Sir,
days.
sorry to interrupt you, sir. Please conclude the session in next 1 or 2 minutes.
Yes. So this is ELA 2022 guidelines. These are not uh, uh, as much important now because we have new just 2024 guidelines according to prognostic risk signatures. If the patient, TP53 mutated patient, the high risk, and if we have any targetable mutation or you have any targeted molecule to that thing, those comes under intermediate or favorable risk. So the higher benefit group as T53, no T53, no FLT3 mutation, and the wild type NRAS or KRAS, and intermediate group if the V has the FLT3 or NRAS KRAS mutated and TP53 wild type. So when plus ASA in the patient as more benefited if the patient is as favorable risk, or if a T53 mutation he has. So these are take-home points. Van plus as an effective and well-tolerated option for elderly and frail patient. It has high remission rates, it prolongs the survival across all age groups, and it maintains the health-related quality of the life of the patient. Then ASA alone. The goal is not just the survival, but also improve the quality of life of the patient. So treatment should also balance the efficacy and toxicity to maintain function, independence, and the achieving remission improves quality of life of these patients. So we have to personalize the adjustment, the dose of these drugs, and continue our treatment according to that. Actually, thank you.
Thank you, Dr. DSG, for this beautiful talk. So I will invite next Dr. Mahak Agarwal. Mahak is consultant in Excel Cancer Center, Delhi, and she will be speaking on, it's a sponsored session by Estelas, and she will be speaking on relapsed refractory AML. Over to you, Dr.
Good
Mahak.
evening. Good evening. Thank you. Can I please be allowed to share my
Sir,
screen?
Dr. Divesh, sir, please stop the screen sharing.
Yeah, I'm doing. I'm stop sharing.
Then we are running slightly later.
Yes,
Sure.
yes.
Yeah.
Just a minute. Yes.
Is my screen visible?
Yes, ma'am, visible.
Yeah. Okay. Hi, good evening, everyone. Today I'll be talking about relapsed refractory FLT3 mutated AML. And as we all know, that this is a very challenging subset of AML patients that we deal with routinely in our practice. And so today I'll be talking about how gilteritinib has changed our daily practice for FLT3 positive AML patients. And I would like to thank Astellas for sponsoring this session and Dr. Prakash for organizing this meeting. So first, let's address what FLT3 is. FLT3 is a tyrosine kinase 3 receptor, and it is normally present on hematopoietic progenitor cells, but and it allows the cells to differentiate and proliferate. Now, AML hijacks this normal process of differentiation and proliferation via the two uh, mutations, the ITD and the TKD. These are the two different domains of the receptor on which the mutations occur. Now, why is it important to know these mutations? We'll just come to it. But what we know is that FLT3 mutated AML is associated with a significantly poorer outcome as compared to non-FLT3 AMLs. And our current approach to FLT3 mutated AML includes induction therapy with a FLT3 targeted agent, followed by consolidation or salvage chemotherapy. Now, yes, we talk about induction chemotherapy, consolidation, and salvage, but the ultimate goal for these patients is bridging to transplantation. So we have to understand that traditionally in hematological malignancies, we have not talked about median survival or relapse-free survival because we talk about cure in these patients, which we can bring about by allogenic transplantation. So these therapies which we talk about are basically targeted at bridging to allogenic transplantation and inducing a deeper molecular response before transplantation to get a better outcome after transplantation. So FLT3 was identified in 1990, after which there were multiple targeted agents that have been discovered since. And like I was talking about the two kinds of mutations in FLT3 receptors, the ITD and the TKD, might be targeted targeting via sorafenib or ponatinib, which would not be effective in these subset of patients. So today we'll be talking about gilteritinib and how it has changed the landscape of treatment for FLT3 positive patients. Why it's important is because gilteritinib has been proved to be effective as a single agent in FLT3 positive AML. So that is very important, that as a single agent, it is very effective. And this, there are two trials that we talk about when we talk about gilteritinib, the Admiral and the Commodore trial, which have put gilteritinib as a pole and a cornerstone in the treatment for FLT3 positive AML. Now, talking about the Admiral trial, it was a randomized study where a vast number of patients, 371 patients, were randomized to receive gilteritinib versus salvage chemotherapy, and then as a bridge to transplantation. So the first and very important observation was that in the gilteritinib arm, there was a doubling of response rate that we saw as compared to salvage chemotherapy. And the median overall survival improved from about 6 months to more than 9 months. And we also saw that 12 months overall survival was more than double as compared to salvage chemotherapy in the gilteritinib arm. And what we saw was also that there is a higher percentage of patients in the gilteritinib arm which progressed to receive an allograft as compared to patients in the salvage chemotherapy arm. Now, while we are saying that there is a higher number, we have to understand that 25 is not really a high number. But yes, it's definitely higher than the salvage chemotherapy arm. So, and even post-transplant, we'll talk about this later, that patients who went on to receive maintenance had a better survival. So yes, we've established that gilteritinib works. Now, does the response sustain is the next question. So a post hoc analysis of the Admiral trial was done for after 2 years. And what was good to see was that not just 2 years, but 3 years and up to even 5 years, this overall survival and the median survival benefit that was seen with gilteritinib versus salvage chemotherapy was sustained. And this was irrespective of the intensity of chemotherapy that these patients received. So coming on to gilteritinib as a bridge to transplantation, what is important is that we talked about that around 26% of patients receive transplantation in the gilteritinib arm. And what we note is that 62% of these patients resumed gilteritinib as a post-transplant maintenance therapy. And patients who resumed gilteritinib, the overall survival is about 40% as compared to about 10% in patients who did not resume gilteritinib maintenance after transplantation, which is a significant difference. And alongside that, what we also note is that patients who underwent a transplant and resumed gilteritinib, the long-term survivors were about 30% compared to less than just 5% in patients who did not undergo a transplantation. So gilteritinib, you have to understand that with gilteritinib, there is definitely a financial burden that we see, that we receive as a feedback from our patients as compared to other FLT3 targeted agents. So at times we have patients who do not respond to gilteritinib as early as maybe even a month or 2 months. So the question arises, do we stop the treatment or do we continue? So the analysis was done to see what is the average number of cycles that patients require to see a durable response. And what was noted was that around 90% of patients respond by cycle 6. So it takes about 6 months to see response in maximum number of patients. And so, and in these patients, then there was a distinction that was made, and patients were divided into early responders and late responders. Now, what is surprising is that patients who responded late also had a better outcome, surprisingly. And so it is, then we think about we continuing a drug for 6 months and even more, what could be the side effects? What is relieving to note is that the side effects are relatively limited to a minor transaminitis, which is reversible in most patients. And these side effects are relatively even lower in gilteritinib group as compared to chemotherapy group. So the standard recommendations suggest that patients should receive at least 6 cycles of gilteritinib before we consider switching to a different agent in view of lack of response. So coming back to patients who underwent transplantation and resumed maintenance therapy with gilteritinib, we see that there is a significantly better outcome, lower response, lower relapse rate, and a better survival in patients who resumed gilteritinib maintenance in in this cohort. However, this analysis was limited because limited by the nature of non-randomization. Coming to just a transfusion burden is definitely lower in patients who receive gilteritinib. Now, we've talked about how gilteritinib improves outcome in patients of FLT3 positive AML, but we are also seeing that this response we are noting is about 30 to 40% patients. Yes, it is 30 to 40% more as compared to salvage chemotherapy, but we have to realize that a vast majority of patients are still relapsing. So yes, there would be a proportion of patients who would respond to gilteritinib, undergo transplantation, and get cured, but these are few. And even after transplantation, a lot of patients are relapsing. So we have to question what better can we do. And with that, we have to understand that what is it that kills the last cancer cell. So when we just one second. So when we talk about allogenic transplantation for cure, we are talking about the graft versus leukemia effect that we see from the donor's immune system. And as per our understanding, vast understanding, is that T cells is what mediates this graft versus leukemia effect. But unfortunately, T cells are also what mediate the graft versus host disease. And it is difficult to dissociate the graft versus leukemia from the graft versus host disease with the T cells. Um, and there is, a complementary population of cells, which is known as the natural killer cells, which are very potent cytotoxic cells. These are fewer in number, but these are very potent. These are in contrast to T cells, which are activated by the MHC molecules. These cells are inhibited by the MHC molecules. So our team that is led by Dr. Suparno Chakravarti, we developed a novel haploidentical transplantation with abatacept and post-transplant cyclophosphamide. And with that, what was also done was as early as day +7 donor lymphocyte infusion was given. And what was noted was that there was a better survival in patients who received abatacept primed donor lymphocyte infusion. And there was we went back to see what is it that is leading to a better survival in patients with uh, donor lymphocyte infusion. And donor lymphocyte infusion at the time of day +7, where it is unheard of that you give a DLI as early as day +7. So what was noted was that abatacept, it not just blocks T cell co-stimulation and helps in preventing GVHD, but it is also promoting NK cell cytotoxicity. So we realized that there was a certain subset of population of NK cells which was expanding early in the post-transplant period, which was providing this graft versus leukemia effect and protecting the patients from relapse in this very relapse refractory setting. So there was we studied as to what are these natural killer cells that are expanding post transplantation, and we found that and with this bench work that we did, we developed a proprietary NK cell product which we give as early as day +7, followed by day +21 and day +35 in patients with relapsed refractory leukemias. And I'm just going to talk about a patient and then followed by a few patients who have received this product. This is a story of a patient who had renal transplant in 2008, and he was detected with FLT3 positive, KMT2A positive, DNMT3A positive AML in March 2023. He received AZA, venetoclax, and midostaurin-based induction therapy and presented to us in June 2024 with a morphological CR but a high MRD on flow cytometry. We chose his brother, who was the donor for the renal transplant, for a haploidentical transplantation. He underwent haploidentical transplant, and so we saw that his pre-transplant bone marrow, he had a high MRD, and we also did a bone marrow for him on day 0. And what was interesting was on day 0, also the molecular the flow MRD remained the same. So what we realized was that it's not the conditioning that is helping in targeting the leukemia cells, but it is something else. So, and then he received this protocol-based therapy where he received Abani 15, the NK cell proprietary product, on day +7, day +20, and day +35. And as you can see from this graph, on day following day +7 infusion, on day +15, when we did a bone marrow for him, he still had some peripheral blood assessment. He still had some leukemic cells, but on day +20, when we did a bone marrow prior to the second infusion, he was MRD negative by flow cytometry as well as by NGS. However, unfortunately, on day +263, he relapsed. He received a HMA, venetoclax, and gilteritinib-based chemotherapy, following which one cycle of it, and he attained negative MRD and received Abani 15 consolidation therapy, following which he remained in negative MRD, and he was continued on low-dose gilteritinib maintenance. So this is an early
Ma'am,
result. This
ma'am,
is the
sorry
last
to.
slide.
Okay,
This is the
ma'am.
last slide. So I'm just showing you the early results from this study, where we have a set of about 12 patients with relapse refractory disease. As you can see, there are patients with blast percentage as high as 40%, 60%, and above 95% pre-transplant on day 0, on day +7. And following infusion of this product, we have seen that most of these patients achieved a miraculous negative MRD and have sustained the MRD negativity up to 1 year of post-transplantation. So the take home that I would like to say from this is that yes, gilteritinib is now the standard of care for relapsed FLT3 positive AML, and the major benefit comes from achieving remission, enabling transplantation, and maintaining disease control after transplant. However, the next frontier lies in combining targeted therapy with cellular immunotherapy to reduce relapse further. Thank you.
Thank you, Dr. Nayak. It was very enlightening and a beautiful
Thank
talk.
you.
As you said, the next frontier is targeted immunotherapy. So I will invite Dr. Priyansi Pachori. She will be speaking on nivolumab in Hodgkin lymphoma. So over to you, Dr. Priyansi.
Thank you for the invite, sir. So I would like to share my slides. Am I audible?
Yes,
Yes,
you are
ma'am.
audible.
All right, all right.
Dr.
Dr.
Nayak, you can
Mehak would
stop sharing.
request you to just stop share your slides.
Sharing and Priyansi, you can continue.
All right.
Do you have any option of
Yeah, sir.
stopping the slide?
Technical team, kindly help.
Actually, I'm not getting the option of.
No, so no.
Okay, no
Help him,
issues,
please.
sir. No issues, ma'am.
Then Dr.
Technical team,
Priyansi can
kindly
take
help.
over.
Yes, ma'am.
So, ma'am, 1 minute. Just we'll need to take a
Yeah, please, yes, sure.
sponsored session here, screenshot, and then.
You can share now, ma'am.
Okay. Can somebody share my slides? I'm not able to get it.
I'll
Sure,
do, ma'am.
ma'am.
I'll do, ma'am.
You can stop share. Yes. Anjali, start sharing.
I hope slides are visible.
Yes, yes, slides are visible. So, um, Dr. Prakash has already introduced me. I am a consultant hematologist in Fortis, Noida, and I would like to address this that while reading this PowerPoint presentation itself, I have learned lot many things. Irrespective of all the trials which are happening in clinic, when we sit in a clinic and see real life patients, the patients are entirely different. Like there are patients who have renal abnormalities when they come with Hodgkin's lymphoma, along with cardiac abnormalities. And there is still lacunae in these patients where the treatment guidelines should be decided. However, these studies, which I'm going to discuss henceforth, are going to help many of us deciding treatment plan of our patients. Okay, I'm not able to see the slides. Just a second.
Next slide.
Okay, I'm not able to see my slides itself. Just a second.
Ma'am, can you see the screen?
No, I'm not able to see the screen actually. Just a second.
Hello.
Yes, Dr. Priyanka.
Okay, fine. So I can see my screen. So today I will be speaking about nivolumab. It's a very highly effective checkpoint inhibitor, anti-CD1, which is approved for relapsed refractory Hodgkin's lymphoma following failure of autologous stem cell transplant, along with brentuximab vedotin. It provides durable high response rate of around 66 to 87% and is now used as a combination with AVD as a frontline, less toxic standard of care for advanced stage classical Hodgkin's lymphoma. Next slide, please. Nivolumab as a monotherapy is prescribed for the treatment of adult patients with classic Hodgkin's lymphoma that has relapsed or progressed after autologous stem cell transplant and brentuximab vedotin, or at least 3 or more lines of systemic therapy has been used. In the 3 line of therapy, autologous transplant is also there. So it is used in those set of patients who are refractory to many lines of therapy, at least 3. Frontline setting, it has been recently approved by FDA to be used along with combination of AVD for patients more than 12 years of age. who are previously untreated, stage 3 or 4, that is your advanced stage Hodgkin's lymphoma. Next slide, please. Classic Hodgkin's lymphoma is characterized by genetic alteration, causing overexpression of PD-L1 and PD-L2 on RS cells, allowing the cancer cells to evade the immune system. Nivolumab blocks this interaction. That is the mechanism of action. Next slide, please. So in frontline, which line we should use? So in frontline therapy, the SWOG protocol is there, trial is there, where they have demonstrated that if we use nivolumab AVD, they have superior PFS as compared to BV AVD in advanced, that is stage 3, stage 4 classic Hodgkin's lymphoma. And it is a very good drug for relapse refractory cases, very crucial in patients whom we are bridging for allogenic transplant with high unmet needs, with a 12-year overall survival of almost 95%. Next slide, please. So this SWOG is a S1826, a very important randomized study which was done on nivolumab AVD versus brentuximab AVD. Head-on trial was there in advanced stage classic Hodgkin's lymphoma. So it is very mandatory to understand that they have taken this pediatric age group as well, like 12 to 17, 18 to 60, and more than 60 years. They have taken all these patients, and the patients who are advanced stage with a creat clearance of more than 30, with a good ejection fraction, and okay LFT and KFT, these patients should not be having ILD or pneumonitis, active autoimmune disease, or a peripheral neuropathy of grade more than 2. So they have given nivolumab and AVD on day 1 and 15, 6 cycle, 20 days, 28 days apart with a graphel optionally given. And head-on in 50% of the patient, they have given brentuximab vedotin day 1 and 15 along with AVD, graphel as and when required. They have given RT to optionally as per physician discretion. 994 patients were there, out of which 50% patients were of nivolumab AVD and 50% patients were of brentuximab AVD. Next slide, please. So, next slide, please. So it is very necessary to understand that the 2-year progression-free survival was in nivolumab AVD was 92% and in brentuximab AVD was 83%. Better in nivolumab AVD. We should also see that in nivolumab AVD, 9% patient discontinued treatment-related issues, and brentuximab AVD 22% patient discontinued. And the grade 2 neuropathy, more than grade 2 neuropathy, was in nivolumab AVD was 3. However, it was 32% in brentuximab AVD. Next slide, please. Next slide, please. So, nivolumab AVD demonstrated superior 3-year PFS versus brentuximab AVD alongside a very manageable safety profile, supporting its consideration as a first-line treatment option in adolescent with advanced stage classic Hodgkin's lymphoma. Young adult group of 12 to 17 years. Very important. See, many patients walk into our OPD who are older patients. So they have also taken considered patients who are more than 60 years of age. They were comprising 15 to 25% of the population, and they struggle with many specific standard of care treatment option because they have difficulty in tolerating chemotherapy, often receive lower doses or fewer cycles as compared to their younger counterparts, can experience treatment related morbidity and mortality. So this is a very good study which supports the fact that nivo AVD can be used in patients who are more than 60 years of age and are newly diagnosed advanced stage classic Hodgkin's lymphoma.
Sorry to interrupt you, ma'am. You need to conclude in next 2 minutes.
Oh, okay, fine. So let's go to the summary. So in this particular study, nivolumab beyond progression, classic Hodgkin's lymphoma. Just can you give me 1 minute? Can you just go back, like 2-3 slides back?
Sure, ma'am. Do let me know where I have to stop.
Yes. Please go back. Please go back. One more. One more slide. One more slide. One more slide. Next slide, please. Next slide. Next. Yes, next. Next slide. So I will just, in 2 minutes, I will conclude this particular study. This is a Checkmate 205 study, which was nivolumab beyond progression in classic Hodgkin's lymphoma. See, in this particular study, they have considered patients which we face in our clinic, like adult patient who was relapse refractory after autologous transplant, failure without brentuximab vedotin, cohort A, with brentuximab vedotin after transplant, cohort B, and patient who have undergone transplant and has received BV before and after transplant, cohort C. They have received nivolumab 3 mg per kg IV every 2 weeks, and they have continued the nivolumab until the disease progresses. Okay, so now here the end point was the tumor burden change more than 10%. Next slide. Next slide, please. Next slide, please. So the a median follow-up of next before that. Yes. So a median follow-up of 58.5 months. So the overall response rate was 71% with a CR of 21% in such a cohort which was like heavily pretreated patients. The CR was highest in patients who were naive to BV, that is cohort A, who has only received transplant, compared to those who has a prior BV exposure, that is cohort B and C, where it was given before and after transplant. So the median duration of response was 18.2 months with a CR of 30 months and a PR of 13.5 months. And this is also important to understand that when we should tell the patient, okay, you will achieve a response. The median time to response was 2 months. And the time to achieve CR was 4 months in both, which was similar in all cohorts, that is A, B, and C. Next slide, please. Next slide. So a total of 58 patients received subsequent hematopoietic stem cell transplant, and more commonly in cohort C than in cohort A, because the A was not exposed to BV. Patient received allogenic transplant at the median of 63 days after their last nivolumab dose. Among the patients who received allogenic transplant, 29 were in CR 2 years after transplant. So the disease biology is very important. So the patient who has not received BV prior to transplant or after the transplant respond better. Next slide, please. The Checkmate trial confirmed durable responses, particularly a long duration of CR and favorable OS with nivolumab in patients with relapsed refractory classic Hodgkin's lymphoma for whom autologous transplant has failed, irrespective of their BV treatment, that is cohort B and C. These results also suggest that it may be feasible for patients to discontinue treatment after 1 year of their CR, and we can reinitiate treatment upon the disease progression. I have like 2-3 minutes more, or
No,
is it like?
Dr. Priyanshi,
No,
we are.
sorry, ma'am.
Okay, fine. So, like, I would just like to end one thing that I have one patient who's a young adult patient, and that patient is having ejection fraction of 20-25%. So, in these kind of patient, it is very, there are no good guidelines which are there that what type of therapy we should use, like dacarbazine ABD we should use, or brentuximab vedotin plus nivolumab we should use. If I would have time, I would have discussed the same. Similar kind of situation might be there, and we should not shy away from using these newer therapies where we cannot give chemotherapy, because we need to achieve good
Yes, yes.
CR. Like in an interim PET, we need to have good response. So that is.
I would have loved to treat this as a BB Nivo combination for a male with 25% EF. Treat it like a 78-year-old male. Similar to BB Nivo. Anyway, it was a very beautiful talk. Thank you. So for our next session, I would like to invite Dr. Rajan Kapoor sir. Sir is Visis Seva Medal awardee and is commandant in charge in Leh, and sir will be speaking on EHA updates in acute lymphoblastic leukemia. So over to you, Rajan sir.
Hi, Prakash. I'll just see if I can share the slide. I,
Just give us 1 minute, sir.
okay. Wait. Nice seeing you, Prakash. How are you doing?
I am fine, sir.
Great. You are in
Learning
Jaipur?
hematology. Yes, right now I'm in Jaipur.
Oh, great.
Since
I am
you
from
since you
Jaipur.
were in Kolkata commandant, na?
Yeah, I am
Command
from
also.
Jaipur. I'm
Yes,
from
I
Jaipur.
know.
So I'll
I know,
come and
sir.
meet you someday.
You can share your screen.
Yeah, I'll just try doing that. Yeah, I think the slides are being with. Hi, Ashok. Good, nice seeing you. Wait a second.
Yes, sir, it's done, sir. In
It's done.
PPT mode.
Yeah.
Yes, sir.
Chalo, first up, thanks, Prakash, for giving me this opportunity. And actually, since I'm not practicing active hematology there in Leh, so it's always a welcome change listening to all bright young minds. So, thank you so much. And it's good to see Ashok there.
Thank you.
So,
Sir,
how
how
are you,
you
Ashok?
are? Sir, you are in Ladakh now, na?
Yeah. You please do plan.
Sir, plan
So,
कर रहा हूँ जल्दी plan कर
yeah,
रहा हूँ.
all of you should plan at least. That should be a big takeaway from this talk of mine. So, so Prakash had asked me to select two abstracts in ALL. So I thought one we would concentrate in one aspect, which is I think we have now come to the crossroads as far as ALL high risk management is concerned. And the most important thing which a hematologist and a transplanter encounters, what after induction? What do we do for consolidation? So earlier it was just transplant for high risk. And as we all know, hardly in our country, probably 10% of the people would probably get the transplant. So what to do
Sir,
about?
you need to invite your panelists, sir. Apart from Dr. Ashok.
I'll just do that. So, so we have to discuss these things. We have three panelists. So first is Dr. Ashish Verma. He is a consultant at Apex Hospital, Jaipur, a BMT physician. Welcome, Dr. Ashish.
Good evening, sir.
Then, good evening. And then is Dr. Akshay Lahoti. He's from Indore. He's assistant professor in a super specialty hospital, MGM Medical College. And then my
Good evening, sir.
good evening. How are you? You are in a
I'm
car.
good, sir.
You're always mobile. Chalo, that's good. So then last but not the least is my dear friend Dr. Ashok Kumar Rajoria, whom he keeps inviting me, but I'm somehow not able to travel the distance to Gwalior. But I do expect that he comes to Leh. So welcome all the panelists, and then so these are the three two abstracts which I have chosen. So let's discuss this consolidation, and heartening to know that the second abstract is from our own country, from the Tata. So that's good that now we are having abstracts and podium presentations in a big conferences. So just to set the ball rolling, the important thing is what to do for consolidation. Now, in generally, what we do is after induction, if the MRD is positive, we continue with the chemotherapy, and some people go for high risk these protocols, HR2, 3, or any other intensive protocols, and try to bring them to MRD negativity. Because as you would agree, if in ALL MRD is positive, short there is going to be a relapse. So even the BMT does not have that much of an effect in MRD positive ALL, because the graft versus leukemia effect is not that potent as in AML. When we have an AML, we do transplant while having disease and blast, but in ALL, MRD positivity, doing a transplant is burning your fingers. So what is the advantage of immunotherapy? So you have targeted antigens, the CD19 being the commonest. You can have a deep molecular clearance, and if you're not giving very heavy chemotherapy, then there is preserved quality and safety. So this is the first abstract, that is S103. This is swapping high dose chemotherapy for blinatumomab. Now this is AIOP BFM ALL 2017 trial by Dr. Martin. So there were 768 newly diagnosed high risk BLL. Now the BALL, the high risk, they said one is at beginning because of the cytogenetic markers if they were ALL, or they had persistent MRD positive too. So these were the two groups of people in this 768, and this is a pediatric protocol. Now what they did is all of them went standard induction. All patients underwent frontline induction, consolidation, and one highly intensive chemotherapy block, HR1, which is there in BFM, prior to randomization. Out of these, then they had randomization. 351 went to the chemotherapy control arm and 352 blinatumomab. Now, experimental arm completely replaced HR2 and 3 with 2 cycles of blina. So this is what the thing is. If you see this diagram which I've made, so you have standard induction, chemo block HR1, then you do randomization. Control arm continues to have intensive chemotherapy, and then they went for subsequent consolidation or maintenance. Now experimental arm, they had 2 cycles of blina and 2 doses of IT methotrexate. And after that, as per the investigator's choice, whether they went for transplant or subsequent maintenance, this is not clear in this abstract, so I couldn't see the full paper, but I'll come subsequently about the transplant experience. Now, what are the indication of SCT? Almost 10% of high risk had indications for SCT in first CR1. So, a persistent MRD positivity or a very high risk cytogenetic. So that was investigator's choice whether they want to take up for transplant or not. Now, what is the efficacy data? So if you see the endpoint, 83% versus 70.3%, and with a hazard ratio of 0.51%. So this is very significant. And cumulative disease of relapse, incidence of relapse was almost half. So this has been a very important paper. We had it in adult also, but this is in pediatrics. Now, in the deep biological responses, the CNS relapse rate was only 0.3%. And the second point, which is very important, if the MRD was positive, almost 80% of the cases cleared of their MRD after blina, which is a huge thing. And if you see the EFS advantage MRD group, the 4-year EFS benefit was prominent in patients with MRD positivity. So this is the group which is the most difficult and hardy to treat in pediatric ALL, and blina was undisputedly shows advantage in this. Now, if you see the safety profile, there were only 22.8% had significant infections, and almost 70%, as we know, it's the Western data here. If you give an HR2 and 3, I'm always scared to give these HR blocks because almost all of them would have a severe infections or mucositis. Only thing which is important which we are going to discuss is the neurological events, which are more. And important thing is very important for the transplanters. There was only 2.5% mortality in blina arm. So we know if you give too much of chemo before transplant, the outcomes are bad. So with this background, I think we can start with our panelists. We'll reverse the order. The first one, probably Dr. Ashok can take. So these are very exciting times for ALL treatment. Seeing this data, if you think, should we, in a high risk patient, if finances are not an issue, we will come to that issue later. Do you think all newly diagnosed pediatric BALL, irrespective of their MRD, we should employ blina in consolidation? Dr. Ashok.
So I think, sir, if financially is not issue, or this trial, this data is very promising, so result is very good. And if you patient after induction MRD positive, high risk, if you want to consolidate, then sir, is immunotherapy is a good option because of the intense chemotherapies literally, agar if you doing the intense chemotherapy, so much of the infection, so much of the ICU admission, so much of the, so I think so cost wise be if you have seen na, so
Right.
like na equal. So I think I support ki if I financially not issue, then I just go for the wellness in this setting. Yes, sir.
No, thank you so much, Dr. Ashok. I think you have summed up very nicely. Just
But in my setting, I don't have seen last time practicing in the Gwalior last 5-6 years.
yeah.
Finance is very important.
Yes, yes.
No
Yeah,
patients,
yeah.
nothing. Patient not having the much of money for the literally intense chemotherapy with
Absolutely.
the government fund.
Yeah, absolutely. But you have brought out a very good point, which I mean, personally, I also don't have a very high experience with Bilina because it is not freely, I mean, it's not available as of now in India. I think you have to still import it. So probably it would get launched. So then we probably would be using it more. But what you had pointed out, because even the chemotherapy is not very cheap
Yeah,
in
obviously.
India because if this HR2, 3, they are admitted and there are so many infections.
So much
So
of
yes,
expense.
yes. So if supposingly somebody is able to get it, it makes a good.
Go for the immuno.
Yeah. A second, I'll just. Yeah. Yeah. So that is now coming to the second question. Now, this would be to Dr. Ashok Akshay Lahoti. Now, have you used Blina in your practice?
Sir, I had the opportunity to see one patient undergoing blinatumomab therapy, and that was an adult ALL patient at Tata Medical Center, Kolkata.
Right, right. So, what
So
was your experience?
somehow,
Yeah.
but only on the second day she had developed this ICANS, so we were not able to give the full dose. So now
Okay.
that was a challenge.
Right.
So practically in the pediatric, we have not seen much. So I haven't used it, sir.
So, do you think once it gets available, we'll be using it more? I mean, what would be the, uh, I mean, it's like, what is your practice when you do consolidation? Do you keep them admitted or it's a pediatric, I mean, so OPD based treatment as far as consolidation in ALL for children?
So now, always there is a challenge of the MRD positive patient and the high risk population. For the
Yeah.
other patients, it is not a problem because once you have MRD negativity post induction, you are very much comfortable undergoing or continuing this chemotherapy. But the
Yeah.
MRD positive patients, if you are supposed to give any hypersevere therapy or something else, it is a challenge. Once this blinatumomab is available, probably this will be used more often as compared to the other chemotherapeutics for all these high risk patients, sir.
But I think even in our country, probably it would be an inpatient because 28 days intravenous. I feel that we'll have to make
For
protocol
sure.
because the specialized
Yes.
pumps and catheter care would be a big challenge. I think so that is there. But yes, you are right.
Yes, sir.
So probably outpatient. I don't see outpatient as an option, at least to begin with in Blena. So probably we would be doing an inpatient and trying to do it. So very well said. So the third question, actually, he has just pointed out to this would be for Dr. Ashish. Now we are using a lot of CAR Ts and these bites. So the neural. So what are the monitoring and interventional protocols? Because we'll have to put them in place, as he had just pointed out, Dr. Akshay, that the second day only ICANS had occurred. So what monitoring intervention protocols, any predictors do you think we should be focusing on to predict neurotoxicity is going to occur or not?
Personally, I have one experience during my residency for Belina that we have given in the pediatric patient because of persistent MRD positivity. And for the neurotoxicity part, in relation with Belina, I think 20 to 50% of patient have neurotoxicity, and it will happen if it will occur, it will happen in the starting phase of the therapy within I think 10 to 15 days.
Yeah.
So we have to very vigilant around about this neurotoxicity. We have to examine neurologically, I think, alternate day patients. If there are any concern, we have to grade the neurotoxicity depending upon the grading. I think with grade 1, mild grade, we can just observe, and higher grade, we have to interrupt the therapy, and I think we have to start some steroid or some if patient develop icons like Akshay has told.
Yeah.
So I think anakinra or tosi is also on the.
Yes. Absolutely. So that's very valid point. I think you have summed it up well. So we have to be ready that it may occur, because in the trial it is 11%, but as you said, it up to 25% in certain things in a high risk group, they will have it. So we should have, before we start using, take the neurology team also in the picture. So as you had said, make those things like we do with high dose RSE, the handwriting assessment, spelling challenges, so that when you have, say, a grade 1, as you said, fine tremor or speech impairment, you know that it can go into full-blown ICANS. So that is required. And I think there is a paper which says that EEG also needs to be done, the wake EEG, which can be done, the portable one, which can be done at the bedside.
Sir,
So
sorry to interrupt you, sir. Please conclude the session.
please, okay, so I'm just finishing. So I thought it was 20 minutes. I'll just finish it off. So then we can do steroid and permanent discontinuation. So we'll just skip this. We will do that. Okay. Okay, so we'll straight away, since there's a paucity of time, the second abstract is the frontline CAR T cell consolidation. This is very important because this has come from India, from Dr. Hasmukh Jain and his group. So they were 29 adolescent and adult patients with a median age of 25 years. So what they did is, if there was a persistent induction MRD more than 0.01% or chemotherapy ineligibility. So most of them were persistent MRD positive and they went in lymphodepletion. So they had a high risk. They did a bridging therapy, maybe a hyper CVD, lymphodepletion, and Talicel. Now this is very important that they had BCR-ABL fusion, BCR-ABL or TP53 alterations also in this high risk group. So important thing is just to see this phenomenal clinical results from our own country, our own make in India CAR T product. There was 100% MRD clearance on day 28 and 83.5% event-free survival. And without transplant, this is the most important figure. There was no transplant. And this is kind of a Kaplan-Meier curve, which we all want to see with this CAR T. So this is a precedent setting. So I'll come back to Dr. Ashok. Do you think CAR T in near future coming as a first line consolidation in high risk ALL?
So, yes, sir. If you have financially not a burden like a Western CAR-T, like we have CAR-T right now in incorporated. So, high risk ALL patients and like a belantamab, so much of the icons and all ICU setting admissions. And CAR T cell therapy is a deep molecular response. But right now, no doubt, is a 1 year data, only just 1 year data, just like a deep molecular response and all. So need a future is a more data, then we'll obviously I just go for the standard cure for the no doubt. Just go for the CAR T cell therapy after in the high risk patient if they people are affordable and all. Yes,
Good. So that's a very good thing, encouraging thing that we
yeah, well,
know.
yes, encouraging data is by the data memorial. Yes.
Yeah. So I'll just go to Dr. Akshay. Now, do you think after CAR T, do we need to give any maintenance? Like in this study, they have not done transplant at all. So do you think that probably we can avoid transplant in such patients if we give CAR T and no maintenance?
So now this is a topic to explore.
Yeah.
There are two schools of thoughts. Probably you need to go ahead with the transplant post CAR T in all the high risk patients, or probably you need to monitor their MRD every month or 3 months. And based on those parameters, probably if the MRD was positive before transplant doing a CAR T, then probably allogenic transplant helps as a consolidation. But for those patients who were MRD negative before CAR T, probably you can skip the allogenic transplant. So that is what the thought is. But yes, there is a role of some consolidation in few patients.
Yeah. So you
Yes,
very
the
well.
CAR T also, sir. This is the reason persistent of CAR T cells. CAR T
Yes,
cell is
yes.
alive. So
Yes.
so much of
Sir,
so
in the
much of
interest of
the thing.
time, we have
Yes,
to Wrap up, sir.
I will just finish it off. So as we have said, in patients who are mainly having MRD positivity. So Dr. Ashish, have you had any CAR-T experience in pediatric ALL or?
Sir, not yet for CAR-T patients, but we have a tie-up with one or two companies. So we have I think we have one patient who relapsed post transplant. For that, we are planning for CAR-T, but he went to Tata Bombay. So
Only one
personally, I have
experience.
no experience.
So we have done, means we've gone into double digits and crossing 20. So what we found is one important thing which I just wanted to share is that if use of tocilizumab with CRS. So if you only have grade 0 or 1 CRS, sometimes we tend to give more tocilizumab. So tocilizumab is associated with more HLH. That's what we found, and hemotoxicity later on. So you be very careful when you use tocilizumab and other biologics in CRS, probably better to avoid in grade 0, 1. But I'm sure these are exciting times and we'll have much more consolidation strategies. Thank you, Dr. Prakash. I think we are running short of time, so it could have gone on and on, but we'll have to stop now. And thank you all the panelists for a very lovely discussion, Dr. Ashish, Dr. Akshay, and Dr. Ashok. Many thanks to you.
Thank you, Raj.
Thank you. Thank you to the AAA. And now for next session, I would like to invite Dr. Naveen Gupta. Dr. Naveen is professor and head at Mahatma Gandhi Medical College, Department of Hematology. We will be speaking on Janubrutinib. Dr. Naveen, over to you. This is a sponsored session by Glenmark.
Thank you once again, Dr. Prakash. And just share the presentation. Not able to share. I think the previous one has
You
to
may
be.
share your screen now, sir. Or shall I share?
Yeah. I hope it is visible.
Yes, sir.
Yes, it's visible.
Okay, so in this session, sponsored by Glenmark, I'll be discussing the role of zanubrutinib in the management of lymphoma, and basically it's another one of the BTK inhibitors, a covalent irreversible BTK inhibitor. And so BTK is really important for B cell signaling, and the role of BTK inhibition is there across a lot of B cell malignancies. And if you look at zanubrutinib, it forms a covalent bond with the cysteine residue, which is the same site as any other irreversible covalent BTK inhibitor. So what exactly does make it different from the other BTK inhibitors? So that would be the selectivity. So all basically small molecule inhibitors can have off-target effects. They can inhibit other tyrosine kinases, and that can lead to off-target effects. So that is significantly reduced with zanubrutinib, which renders a much more favorable toxicity profile, particularly when we compare it against ibrutinib. Also, it carries a few advantages in terms of it has a stable PK profile, which is not affected by high calorie or high fat diets, gastric acid reducing agents, or oral anticoagulants. Also, the dosing schedule can be flexible. We can either give it 320 milligrams in a single dose, that would be 480 milligram capsules, or it can be given 160 milligrams 2 times in a day. That would be 2 capsules in the morning and 2 capsules in the evening. Both are considered to be equivalent, and that is something that, depending on the patient's preference, that can be decided. Also, with mild to moderate hepatic impairment, it has no effect on the basic action in pharmacokinetics or the toxicity, so it can be safely given. And for severe hepatic impairment, we will have to reduce the dose. So now the approved indications. So it is a BTK inhibitor with the most comprehensive label across B-cell malignancies, with approvals in CLL, SLL, Waldenstrom, and progressively increasing indications in mantle cell, marginal zone, as well as follicular lymphoma. So initial discussion will be focused on CLL, which is where the earliest and the most prominent benefit was there. So this is the Alpine trial, which is a head-to-head comparison of zanubrutinib versus ibrutinib in patients with relapsed refractory CLL or SLL. A phase 3 randomized trial with the primary endpoint of overall response rate and the key eligibility being relapsed refractory CLL or SLL requiring treatment with no prior treatment with a BTK inhibitor. And this had sub-stratification based on the presence or absence of deletion 17p and p53 as well. So 1:1 randomization, zanubrutinib 160 milligrams twice a day versus ibrutinib 420 milligrams once a day till progression. So the primary endpoint being the overall response rates, and the overall response rates were superior with zanubrutinib as compared to ibrutinib. So this is a unique situation where a BTK inhibitor has outperformed another BTK inhibitor. Prior to that, only comparable efficacies were demonstrated, but zanubrutinib was observed to have a much better overall response rate, which translated to a superior progression-free survival as well. And this is for all patients. And if we specifically look at the high-risk group, the deletion 17p and the p53 ones, over here also it's a significant improvement over ibrutinib in terms of the PFS. So good PFS benefit and overall response rate benefit while having a much more favorable toxicity profile is what makes zanubrutinib more exciting for us. A Sequoia trial, this is comparing it against bendamustine and rituximab, which is often the go-to regimen for patients in untreated CLL or SLL. And as we have seen with other BTK inhibitors, zanubrutinib has a better efficacy. So the trial design, I'll just go through the schema once again. So you have cohort 1 without deletion 17p, which is 1:1 randomized between BR and zanubrutinib. And the ones with deletion 17p, there are two cohorts. Cohort 2 is zanubrutinib till progression, and the cohort 3 includes zanubrutinib with venetoclax. So this is a when-based combination with the BTK inhibitor, which we have seen to have really good efficacy. And we have time-bound, time-limited fixed duration treatments with the addition of venetoclax. So this trial had these three interesting cohorts. When we look at comparison between BR and zanubrutinib, a much superior progression-free survival in the with the zanubrutinib. And if we look at the IGHV mutated and the unmutated groups as well, then this response is rather much more even prominently stark and more highlighted. So much superior progression-free survival with this BTK inhibitor as opposed to BR. And in the patient with deletion 17p, this is cohort 2, the overall survival and progression-free survival is quite remarkable. And this is the fourth arm, or what we call the cohort 3, which has combination of zanubrutinib and venetoclax. And this is again in a really high-risk population. We have really good responses, PFS to the tune of 87% at 36 months. So the combination showing 24-month PFS of 92% with a very high overall response rate of 97.4. So this is also favorable. Now there is no head-to-head comparison between zanubrutinib and acalabrutinib. So again, this requires maybe twisting a little bit of the data to get the information that we want. And we can say that post-matching analysis, we may find zanubrutinib to be superior, although must be interpreted with the fact that these are not head-to-head comparisons. Network meta-analysis showing superiority. Again, network meta-analysis showing comparable responses with venetoclax or obinutuzumab, which is again one of the standard frontline regimens in CLL. Again, with the caveat that this is not a head-to-head comparison. Waldenstrom again is another important indication for this drug. Zanubrutinib was compared head-to-head with ibrutinib in patients with Waldenstrom's in the Aspen trial. The primary endpoint being the CR and the VGPR rate. Patients randomized 1:1 in zanubrutinib and ibrutinib until progression. And comparable response rates seen with ibrutinib and zanubrutinib. Not superior with the zanubrutinib arm, but comparable to the previous standard of care, which is ibrutinib. And this is maintained across the various subgroups like CXCR4 wild type mutated as well as the and the WIMP groups. So, and the response is also maintained across treatment naive as well as relapsed refractory patients. So the thing which interests us the most is what is the safety profile. So if we are using a new BTK inhibitor with a largely similar mechanism of action, but a purported better selectivity for the proton tyrosine kinase, then we should get the benefit in terms of toxicity. So there is lower incidence of adverse events, particularly if we look at infections. The blue bars indicate the percentages with zanubrutinib. So we can see infections, hemorrhage, thrombocytopenia, secondary malignancies, anemia slightly lower. Neutropenia slightly on the higher side. Infections, a significant difference. And when we look at cardiac toxicity, the rates of atrial fibrillation and ventricular arrhythmias both are reduced with zanubrutinib as opposed to ibrutinib. This is somewhat similar to what we observed with acalabrutinib versus ibrutinib, that the cardiac toxicity of acalabrutinib was superior. With zanubrutinib, again, that is maintained, along with a superior PFS as well as response rates, particularly in CLL patients. With mantle cell lymphoma, in relapse refractory, this is a single-arm study showing good responses. Mantle cell is responsive to BTK inhibitors. We have approvals both in the frontline as well as in the relapse refractory setting for other BTK inhibitors, and zanubrutinib has shown good efficacy in this group. So these are a few interesting combinations. So for older patients who are unable to tolerate more intense regimens, zanubrutinib in combination with rituximab has shown good results. And you have zanubrutinib plus bendamustine rituximab in newly diagnosed mantle cell. And this is a small data of 20 odd patients, but again, good overall response rates exceeding 90%. So although this is not a current approval in the front line, but there is exciting trial data that this might be available to us in the front line along with ibrutinib, which is already. So the guideline recommendation, if we go by the NCCN guidelines, currently CLL and SLL, category 1 in frontline as well as later lines. In mantle cell, in the second line, in Waldenstrom, in the front line as well as previously treated ones, in marginal zone lymphoma for second and subsequent lines, and in follicular lymphoma in combination with obinutuzumab in third line or subsequent therapy. So 5 approved indications, including 2 in the front line, which include Waldenstrom and CLL. So to summarize, it's a next generation BTK inhibitor, one of the group of the covalent irreversible BTK inhibitors, but with more selective BTK inhibition leading to low off-target activity and consequently lower toxicity, and a superior PFS in a head-to-head trial against ibrutinib, which is something unique. And it has a really comprehensive label across various B-cell malignancies. And it can offer another weapon in our armamentarium in tackling these malignancies. Thank you.
Thank you, Dr. Naveen. It was beautifully explained and well in time. So double thank you to you. For our next session, it's a sponsored session by Ross, for which I would like to invite our moderator, Dr. Seema Bhatwarekar, ma'am. She is a hematologist and transplant physician at HOC, Vadodara. And ma'am will be speaking on driving change in first line DLBC. So, madam, over to you. Now you can invite your panelists. I am one of them. I am from Cell Journey. Yes, you can do it. No, ma'am, you are mute. You need to unmute yourself.
थोड़ा थोड़ा गाना मम्मा लगे मम्मा लगे
Ma'am, you will be sharing your screen or shall I share? Ma'am, you are muted.
Dr. Seema, you have to unmute yourself. Kindly unmute, ma'am. Technical team, can we do from our side? Support team, can we do it from our side? Ma'am, you need to unmute. She's not able to hear.
Someone can call her and tell her.
Yeah. So technical team can also do some. 1 minute.
So till the time ma'am joins, I would like to invite my co-panelists as host also. So we have Dr. Manoj Mahajan, sir. Sir is Director Medical Oncology, Udaipur, RS Health. And Dr. Ajay Yadav, sir. Sir is Professor Medical Oncology at Mahatma Gandhi Medical College.
Good evening, Prakash.
Yes, good evening, sir. And my colleague, Dr. Ashish. Dr. Ashish Verma is consultant hematologist at FX Hospital, Jaipur.
Good
good
evening,
evening
Dr. Prakash.
good evening good
Good
evening
evening. Good evening,
audible
Manoj, sir.
yes
Yes, we are audible. Man is, I think she is would not
yes
be hearing
some
us.
problem for
And
unmuting yes okay
Pooja, please give her a call on mobile. Now, the technical team, please unmute from your end if possible.
Ma'am is joining again.
Okay.
Ma'am, now please try to unmute yourself. Dr.
Technical
Seema,
team,
ma'am.
can we do this from our side?
Please unmute. Tech support, please unmute Dr. Seema, ma'am.
We can unmute ma'am.
Tech support, kindly help.
Ma'am, we can send them request.
You can't unmute her.
Now ma'am is unmuted. Ma'am, please, you can.
Ma'am, can you speak? We are not able to hear you.
Ma'am, you will join with 2 device?
Anjali, can we share the PPT from our side?
Yes, ma'am, sharing.
Ma'am, can you hear us? Dr. Seema, can you hear us?
I hope the screens are visible.
Screen is visible, but ma'am is not audible.
I have told her to join from phone.
Dr. Prakash, you can just start from some introduction or something about the topic.
So this is a driving change in DLBCL. Next slide. We all are treating. So I would like to have an apology first. Seema madam is unable to connect because of some technical issues. So I want to go ahead. So DLBCL is the commonest NHL we all know. Most of our NHL are DLBCL, 70% of which again 85 to 90 is BNHL. And amongst the NHL, BNHL is the commonest and DLBCL the biggest one, close to 50. And most of the time we are treating DLBCL with ARCHOP. Next slide, approximately 25 to 30,000 cases per year. And for last 2 decades, we have been treating with ARCHOP. ARCHOP, no doubt, is a very good and wonderful regimen. And it is showing its result in spite of multiple new combination X additions each and everything. So now we have something which is over and above ARCHOP, at least for a subset of patients. Next slide. So this is a typical journey of DLBCL. Everywhere you see symptom, then you screen and diagnose, and the first line treatment mostly ARCHOP, and approximately 60 to 85% gets in remission with the first line therapy. And then the remaining who don't or those who relapse, then they again go for a second line treatment, depending upon the time to relapse and response to first line therapy. Either they go for a CAR T or they go for a autologous transplant. Then the third line and beyond is very close. So the median overall survival is 7 to 8 months post second line if something is needed. Next slide. So DLBCL and R-CHOP. So who are the patients whom we think that they are at increased risk of relapse?
now it's true.
Seema madam, so who are the patients who are at
Hello,
increased risk
can you
of?
hear me?
Yes, madam, we can hear you, madam.
Yeah, I'm really extremely sorry for all this trouble.
No,
Yeah.
madam, you
No,
can
no, Dr.
continue.
Prakash has taken slightly ahead, and you can like take over from him.
Hello. Hello.
Yes, ma'am, we can hear you.
You can hear me? I don't know what is happening. So can I share my screen?
Sure, ma'am.
Ma'am, the slides are there. You can go ahead.
Yeah.
Shall I share or will you be sharing,
Yes,
ma'am?
sir. Anjali, you share the slide and ma'am will speak.
I'm just sharing the screen.
Okay. Okay, ma'am.
I don't know, that is also, you just share the screen.
You need to stop share, ma'am.
Share, please.
Ma'am, I request you to stop sharing. Then I can share only.
Okay.
Anjali, kindly share the screen.
Hello. Can you hear me now?
Yes, ma'am, we can hear you. So you can go ahead. You need to
Okay,
just
okay.
say next slide,
Yeah.
next slide.
Very good
over to
evening.
you.
And I'm happy to join you all after all this mess up. I'm really sorry for that delay. But I think you have already started with session. So I'll go ahead with this slide. In DLBCL, when patients are on R-CHOP, we have seen a lot good response with the addition of ARC, but still we feel there is something missing, like who are at the risk of relapse on patients on the R-CHOP. Any panelist would like? Next slide, please.
So there are clinical factors. Okay.
So patients who are elderly patients who cannot tolerate the chemotherapy full dose,
Yes.
patient-related factors, age of patient, comorbidities, disease-related factors like non-germinal center type, and double hit or triple hit lymphoma, high IPI. These are the patients who are at high risk of relapse.
Yes. So all these factors which we feel that it is a high risk for curability, there is a unmet need to improve the overall survival and progression-free survival in DLBCL. Next, please. Next, please. Yeah. So we understood over a period of time that there is a cell of origin which makes the difference. Like GCB has a definitely better superior prognosis, and apart from that, with a better understanding of the genetics, we understood that there are certain other subtypes also in genotype in genetics, like there will be certain subtypes in GCB also which will show a poor response, or there will be certain subtypes in non-GCB which may show a good response, which has been clarified in lymphogene cluster, dark zone signature, and GCB signature classification. And with this background, we understood that there are certain patients who are not going to show a good response with the R-CHOP alone. Yes, please. Next, please. Next, please. Yeah, so various actually trials have been done and added certain medication to improve the survival, like enhancing anti-CD20 or addition of targeted therapy, chemotherapy, or maintenance of R. But nothing has worked, and all these efforts were failed, and we were again back to square one. Next, please. So everyone felt that there is a significant unmet need to improve the treatment outcome in DLBCL till next please. Till the polatuzumab was introduced, and in 2022, European Commission and FDA CDSCO in 23 has approved Pola-R-CHP based on its initial primary analysis, 2 years analysis, showing significant improvement in PFS compared to R-CHOP in DLBCL as a first line. Next, please. So having this background, now we'll go for a case studies. The first case is a young patient who presented with abdominal pain, lower back pain, weight loss for 3 months, and lab investigation shows elevated LDH. CT abdomen shows mass in kidney as well as some thickening in stomach wall, which was confirmed with the GI scopy, large gastric mass, and the biopsy confirmed the diagnosis of DLBCL, and it was non-GCB type with double expressor. Fish was negative, so it is not double hit, but a double expressor. The ECOG performance status was 1, stage 4, and IPI score was 3. Next, please. So, any patient we treat with R-CHOP or chemotherapy for DLBCL, we face these challenges. Like first, we find out whether patient is fit for chemotherapy or not. We do the risk stratification, and then third thing comes as a finance. So next, please. So I would like to know from my panelists, according to the available information of our patient, falls in which category? High risk or low risk or standard risk?
High risk is the double hit. There is.
Double expressor.
And IPI is 3.
IPI is also.
Non
Next, please.
germinal
Next
Stage.
slide, please. Yeah, sure. Express. Yes, yes. Yes, Dr. Prakash.
Madam, Manoj sir was speaking. So, is rightly it's a high risk, double expressor, non-GCB, high IPI, and a bulky mass, especially abdominal, kidney, gastric.
Yes.
So, this is a high risk patient only.
Yes. So all these 4, please go back to last. Yeah. So this survival curves definitely shows that IPI high, then non-GCB and presence of 2 extranodal involvement makes this patient high risk and the inferior outcome if we use the R-CHOP therapy in this patient. Next, please. So to improve the survival or progression-free survival in this patient, how will you change the R-CHOP protocol to get the better outcome? Any panelist?
So, yeah, ma'am, yeah, Dr.
Next
Ashish.
slide, please. Please show them the next slide. Yeah.
So, sir, ma'am, it's a high risk disease with extranodal mass with young age. We have an intent to cure the disease in stage 4. So, we have to incorporate some newer molecule with R-CHOP. So, probably Pola-R-CHP with a significant PFS benefit and overall survival as compared to R-CHOP.
Yes. So these survival curves are showing definitely based on the Polaris trial. Our patient has a high IPI score that is 3 to 5. It is showing clearly improved progression-free survival compared to R-CHOP when Pola is added. Next, please. Next, please. Our patient is non-GCB. So if we treat with the R-CHOP, the progression-free survival is hardly 40%. But by addition of Pola, it is going to be more than 65%. Next, please. So Polaris has also, even though we are not doing the lymphogen classification, but it has shown that EZB, MCD, and undetermined subtype, which show a very bad results with the R-CHOP, they get a improved or better overall survival, better progression-free survival with polar R-CHOP. And these findings suggest that polar R-CHIP provides favorable outcomes to distinct molecular subset within the ABC as well as GCB, including dark zone signature positive, EZB and MCD subtypes, which show very inferior survival with the R-CHOP. Next, please. This again shows that our patient was having two extranodal involvement like gastric as well as kidney. And addition of POLA has definitely made a significant change in the progression-free survival. Next, please. So this is a Polarix trial 5-year follow-up, like based on the first 2 years preliminary analysis, they got the approval, and the 5-year extended data also showed that there is a sustained significant PFS benefit, confirming the results from the primary analysis. Next. And the same has been, means if you see the sub-analysis, it shows that polar R-CHIP patients required 23% fewer subsequent therapies versus patients who were treated with R-CHOP. Means second or third line therapies required for this patient is lesser in polar R-CHIP compared to R-CHOP. Next, please. Even though we see that there is no change, much significant, statistically significant change in overall survival, but if you see the sub-analysis, it shows that the deaths in polar R-CHIP group are less compared to R-CHOP, and over a period of time, like 5-year update also shows the number of deaths in R-CHOP were 91 compared to 79, significantly less number in R-CHOP. And why we are seeing survival curve same is because R-CHOP patients have received second and third line therapies, which has improved their overall survival, and the curves are almost looking like same because they have received multiple other treatments also. Next, please. So this is again extended 5-year follow-up, confirms the sustained benefit in overall survival in R polar chip group. Next, please. So everyone agree with the R-Pol chip is the best for the young high-risk patient, like those patients who have a high IPI, who have extranodal involvement, who have a double expressor or double hit, and where we feel that it is not going to do well with R-CHOP, the addition of POLA has definitely made a magical difference in these patients. So do you all agree with that?
Yes, ma'am.
Yes.
Next, please. And what about the safety profile? Addition of POLA, does it increases the risk of neutropenic infection or admissions or neuropathy? Next, please. The analysis of the safety profile has shown that the safety profile remains comparable with the R-CHOP. There is no additional safety concern observed in R-Pola CHOP group. And next, even there was some worry about the polyneuropathy, but as the in polar chip, vincristine has been dropped. Next, please. Next, please. Vincristine has been dropped, and because of that, polyneuropathy incidence has also remained same. It has not increased compared to R-CHOP. So now we'll go to a next case, and that is first was a young patient, and second is a old patient. She is less than 80 years, but she definitely elderly, 71-year-old widow patient who presented with the bilateral neck swelling, fever, moderate weight loss over 4 weeks. ECOG score is 2, she had a comorbidities, hypertension, diabetes, and PET scan shows hypermetabolic diffuse lymphadenopathy with marrow involvement, elevated LDH, IPS score 5, and biopsy shows on top of it double hit lymphoma. GCB subtype, but double hit lymphoma. So next, please. So my questions to panelists is, how are you diagnosing double hit lymphoma by fish in all patients or in selected few?
When we do this in selected few, when we see that they are double expressed at least, and the CMYC is more than 40%, and BCL2, BCL6 actually is positive. In those cases, we order fish. We don't order fish in all patients.
Yeah, because we have seen that in GCB, if we see the double expressions, there is a more probability that there going to be a double hit than in that situation. And even IHC is inferior to some other finer tuning of the genetic classification, which can pick up more double hit lymphoma. Yes, what are the challenges we get in treating the old age high risk patient? Next slide, please. And any panelists want to share their practical or real life experience about this?
Just any take from your side.
So elderly patients are not able to tolerate full dose chemotherapy. That is a major issue. And for these patients who have high burden disease, there are high chances of tumor lysis syndrome. So these patients should be hydrated, and the tumor lysis prophylaxis should be started. Then these patients should receive low dose pre-phase chemotherapy first, Dexa plus Cyclo. Then after 1 week or after 10 days, we can start full dose regime. The other things are multiple comorbidities for elderly patients, which also restrict the chemotherapy regime. We are not able to give anthracyclines to these patients who have cardiac comorbidities. Some patients have renal failure. For that, we are not able to give full dose chemotherapy. These are the challenges in these patients.
Yeah. And because of all these factors, we have a inferior survival in these patients. And on top of it, if they have a double hit or something higher risk from the disease point of view, it makes the response rate further lower. Next, please. So next, please.
Ma'am, sorry to
So how
interrupt.
would
You
you
need to
treat
conclude.
your double hit lymphoma patient with following care? Like if you have a young fit patient or frail, how it is going to change your protocol?
Ma'am, sorry to interrupt. You need to conclude the session.
Yeah.
Okay. So then mostly for a young patient, I will choose R-epoch, and if possible, Pola arch for elderly. No arch for double hit.
Yes. Next, please. So what is the evidence of benefit of addition of polar chip in 71-year-old high-grade double hit lymphoma? Next, please. Please show the curves. Yeah. This is a Polarix data which show clearly high-grade B-cell lymphoma showing the improved progression-free survival in polar chip. Next, please. Especially those who have a double hit lymphoma, they definitely show a better progression-free survival when Pola is added compared to R-CHOP. Next, please. So this is regarding the elderly patient. If you see for the elderly patient, various protocols have been tried, and the most lower one is the Pola R-CHIP. It shows the highest response rate. 2 years progression-free survival is 77% compared to, if you compare all other, they are showing less than 50%, 50 or 60%. most of them are in the range of 40%. Next, please. So addition of one more immunotherapy, like along with R, one more immunotherapy has definitely improved progression-free survival, and 2 years curves definitely show improvement in elderly patients. More than 70 years of age with IPI score 3 to 5 have shown the maximum survival, progression-free survival benefit. Next, please. Again, there is no change in the risk profile, like safety is also of concern in patients of elderly. But here, this all data shows that is comparable with R-CHOP. There was no additional safety concerns observed in Polar R, even in elderly. Next, please. So new EHA guideline also shows that in first-line DLBCL, less than 80 years, the Polar R chip is the treatment of choice, considering if these patients are high risk, having more than 2 risk factors. Next, please. So to conclude the session, I would emphasize this fact that impact of Polarix is very significant. It has maximized each patient's chance of cure, delivering the most effective frontline treatment with comparable safety, which is essential. At this approach reduces the risk of relapse and subsequent need of additional treatment. Polarix is the first trial in over last 20 years to show meaningful improvement in benefit risk profile over R-CHOP in international phase 3 double-blind randomized controlled trial. The long-term follow-up analysis of Polarix study also confirmed the ongoing sustained PFS benefits in Polar R-CHIP. The benefit of Polar R-CHIP holds even more important in India with limited availability of and access to efficacious treatment in relapsed refractory DLBCL. As we all know, most of our patients have a limited finance. So whatever they want to spend is for the first treatment. The follow-up treatment becomes more difficult for relatives, as well as finance also becomes a burden. Next, please. So the take-home message is frontline standard of therapy in DLBCL has definitely shown the significant shift with the introduction of POLA in a form of Polar chip protocol, because it targets the underlying biology of the DLBCL, and it has replaced in POLA, vincristine has been replaced by the POLA, which reduces the risk of the additional polyneuropathy also. And when we see that there are high-risk patients like non-GCB, IPI 3 to 5, age more than 70, we definitely find that R-CHOP is inferior in such patients. And in those patients, addition of POLA in form of Polar chip definitely will improve the progression-free survival. And as we all see that first line is always a best cure, we redefine the cure rate from day one and maximize our frontline cure with the Polar chip. And with this, I would conclude the today's presentation. Thank you.
Thank you, Suma madam. It was
I'm really sorry for so
session.
much of
No,
disturbance.
issue, madam. Sometimes it happens, technical things. Thank you, and thank you all the panelists. Ajay sir,
Thank you.
Manoj sir, and Dr. Francis. For our next session, we are running slightly late, so I'll quickly invite Dr. Vipul Seth. He's a senior consultant and unit head in hematology and bone marrow transplant, Rajiv Gandhi Cancer Hospital, Delhi. So, Dr. Vipul, you can now invite the panelists. I am one of them, so I am self logged in.
Hi, Dr. Prakash.
Hi.
First of all, thank you for the invitation. I've got very high grade fever, and if I talk, I will be coughing. That's why I kept the final discussion only as discussion. So I can just be a bystander. Can one of you all just take and discuss? Because if I talk, I'll just keep coughing. And yep. So can you just remove slides and informally we can discuss the questions that I've just put?
No issue, no issue. No issue. Informally, we can discuss. No issue.
Yeah. Thank you. Thank you. Can my slides be seen?
Yes, sharing.
Bhavesh sir, please unmute yourself.
Yes, yes, yes. I'm unmuting Prakash.
Okay.
So I frame questions. You all can just discuss, and I can just be a bystander if I need to add anything because really sick. I can't. If I speak, I'll just cough. Nothing.
Okay. 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 Thank you that you are well and unwell and still you join. So it's an informal discussion and like we are talking about CAR-T as a standard of care in some hematologic malignancies. Anshit, am I audible?
Yeah, sir.
Yes,
Audible,
yes,
sir.
yes.
Yeah.
So if what will be your approach for CAR-T?
So,
First
right
line,
now,
second line,
whatever
third
the
line,
yeah. So
after
right now,
yes.
whatever the current evidence we have, so there has been multiple phase 3 trials, particularly the Zuma 7, the Transform trial, and the Belinda trial. They have kind of given us good evidence that there are two basically group of patients whom I would like to use CAR-T as a standard of care. One is the primary refractory DLBCLs. Second is the DLBCLs who have relapsed before 12 months, that is early relapse. And then the third group comes where I think the nuances has to be more refined, is to select the patients, because this group is the patient who have relapsed after 12 months or have late relapses. So in this group of patients, again, I would think that still chemotherapy or the standard approach of a salvage chemotherapy followed by an autologous stem cell transplant uh, will give them a benefit. However, if the patients are transplant ineligible, then definitely a CAR-T becomes the standard of care.
So, Bhavesh sir, when do you want to do bridging and all those stuff? You know, some of the DLBCL is very aggressive and you don't have much of time. So, how do you plan in your mind and how do you counsel your patients regarding suppose someone come to you with a relapse and including everything, what is your counseling pattern and how do you sequence and take those decisions?
So currently, Prakash, I think we should counsel these patients upfront. So
Upfront
that
means
upfront that there is a possibility you may require all the other things that relapse. That is number one. This is, it is a very tough call when you relapse and when you are in a bad shape to understand everything. So at least a little bit of idea. 50% chance of you getting cured. 50% chance you may relapse. And after relapse, at least chalk down the plan for them, depending upon the relapse. Now, hearing this, many patients don't take the treatment with you, right? They only want to listen good things. But things are not really good. Most of the patients, right? Offer them POLA or CHP upfront for whatever criteria they fulfill. That's the best. If whatever 7-8% PFS is not a bad idea. 2-year PFS is 7% plus. Not at all bad. And some OS also. Now, once the disease comes back, then doing a biopsy and then counseling them for again salvage plus minus CAR-T. Definitely, no doubt. Now, everything depends upon the sites of relapse, the PFS, how long the disease was in remission, the patient general health, the cost factors, and everything. Now, do I jump to CAR in all patients? Not at all. If they still go into a good partial response or a complete response, even if they relapse early, there is a place for autologous transplant. Now the question is, shall we harvest for 2 episodes? Do two things. One, you harvest the stem cells, and before that, you do the harvest of peripheral T cells and store them. I think the Western world is moving to that, rather than wait for the T cell exhaustion to occur after 2 or 3 lines of chemotherapy. We know that now the T exhaustion is a major factor in poor response. So I heard to a talk around a year ago where they said they do two harvests. One a CD34 for autologous transplant, and before that they do for a T cell harvest peripheral blood, and they store. Now we don't have that facility here. Immunil and Immunoact don't store the T cells for further use. I think we should move to that if we want to eliminate this exhaustion part of it. Second is
Very
there
well.
is something called as holding treatment and there is bridging treatment. So before leukapheresis, it is holding, and post leukapheresis, it is bridging. So many of the patients require a bridging therapy. And then you decide polatuzumab, glofitamab, Jmox, whatever is feasible, practical, available, we do that. But don't use a treatment which is bone marrow toxic, too much of neutropenia, side effects. Then your chances that they will have a good result at the end of the car is little bit less. Some steroids, some radiation, so gentler. The aim is not to put the patient into remission. Bridging therapy is not salvage. It is just holding with good immunity and bone marrow reserves so that the CAR T should expand well without having major toxicity is the aim of the treatment. So gentler it is, better it is. Radiation is the gentlest. That is
Yes.
how I do the things.
So, Dr. Arijit,
Yes,
uh,
sir.
what do you see as a biomarker, or when do you counsel the patient for a CAR T now also? So, what are your two, three, four tests which you look into and explain the risk of increased risk of relapse or not?
So right now there are multiple biomarkers that have been that are being evaluated, and the entire profile of biomarker is slowly evolving. So to start with, one of the biomarker or one of the parameters which I would say which I look into is what is the tumor biology says. So historically, double hit, triple hit lymphomas or lymphomas with very high PDL1 burden or expression, they do not tend to do very well. The second is the cell of origin. The ABC subtype also do not do very well with the CAR. Uh, Few biomarkers like IL-6, interferon gamma, they have been implicated in the probability of increased inflammatory expansion or inflammatory problems that come into complications that come into during the treatment, but I do not know whether they have any real clinical significance pre-CAR to counsel the patients. Yeah, definitely we use them as markers to monitor therapy or to monitor the clinical condition of the patient post-CAR, but I haven't used these markers pre-CAR. Theoretically, there are multiple, again, biomarkers which have been suggested as to the quality of the product. One of them is the presence of more memory and the naive series T cells. So the expression of CD27, 28. So these have been evaluated, but routinely, I don't think they have uh, been a part of our practice as of yet.
Yes, yes. So, Dr. Vipul, any role you do quick success on PET scan or ctDNA, pre and peri CAR T?
So I just agree with everything. We do ctDNA abroad, but it's not available here. Otherwise routinely same. I just want to ask, one person said they do PDL1 expression. Do you do PDL1 expression routinely on all DLBCL?
No, sir, not routinely, but in some cases, sometimes that is a part of the IHC panel which the patient come across, but it is not a part of the workup per se. One of the parameters that I sometimes I get a hold into, or maybe that can be used, is the total metabolic tumor volume. So that is
Yes.
one parameter that may be at least used in our setup, which is easily available.
Yes, yes, Bhavesh, you want to say?
See, Prakash, if you broadly categorize the biomarkers for prediction of response and relapse. Now, first of all, I thought I should thank Vipul for the framing of the questions. These questions are really very well framed. So I thank Vipul for that. Second, if you see the broad category, the disease biology is one category for prediction of response and relapse. Then the imaging biomarker. Most of the imaging biomarkers are not standardized. Third thing is the intent density of the CD19 or the 20 on the tumor cells, not well categorized. Tumor volume, not well categorized. IL-6 not very well categorized. There is even the microbiome of the gut, and then the T cell markers and the patient markers. So there are 3, 4, 5 broad categories under which you can have these things. Now what we can do is LDH, ferritin, CRP, CR or PR, albumin. So these are general categories, and if these all are bad, then the chances that the patient will not respond well is really bad. Extranodal sites, bad. Kidneys, adrenal, lung, liver, bad as compared to CNS and all. So these which can we do at the moment, and they are more or less everybody knows how to deal with that. The remaining we don't even know how to deal with this. So currently we look at only these criteria and tell. And ultimately, Prakash, if we want to do a car, we will do the car, whatever be the marker, right? Here it is not governed by any body. So I have not seen a patient who is said no to car. Have you? Patient is moribund, lying on the bed, on oxygen. Anybody will say he is not a candidate for car. Patient says, I want to take 1% chance. Give the car. Take 1% chance. So all this is semantic for us. But yes, where there is a body to govern, somebody else is funding, then you follow criteria, and then at least 25-30 of your patients will not fit into the criteria. Most
Yes.
of us, we do. But this is just for our understanding and patients counseling. That's all.
Next slide. So comparative positioning across generations, we always believe that the next generation is better, second better than first, and third better than second, and the fourth better than third. So now India is awaiting a third generation car from microcrystal Narika. So what is your thought about this, Dr. Vishnu, regarding newer cars? Second
I
generation we
think,
have seen in their pride.
sir, at this point of time, I think construct level differences are biologically meaningful but not relevant to us, because at this point of time, I think center experience, the manufacturing, logistics, accessibility, patient urgency, I think these factors govern our decision of the product, and we do not have a choice of product at this point of time. However, in case in future, if products are available, maybe a different target like a dual car 1922 car, or using different co-stimulatory molecule CD22 CD41BV, maybe all these things factors will influence our decision making of selection of cars. But at this point of time, I think that it is mostly this all four factors which will decide on the selection, and we do not have a choice at this point of time.
Yes, we don't have the choice, but actually Dr. Vipul is sick, and he was one of the investigator in this third generation car, which has the dual co-stimulatory molecule, CD28 and
So
41BB.
yeah, actually, I had the opportunity to use a few dual cars, if, uh, but this has been so sporadic, and this has been in so less number of patients that giving a conclusion that this product is better than the other at this point of time, I think it is too early to say. But considering the effect that I have, or the data I have from my patients, I have used CD1922 car in two patients, and they are doing very well. It is around 2 years that I have done this. The patients are in remission, and the toxicity was also very less, because again the co-stimulatory molecule used were 41BB. Now it is always said that 41BB has less toxicity than the
Milder.
CD28.
Yes.
Yeah,
Yes.
CD28. So this is my
So
experience with this.
yes, right. So, Bhavesh sir, regarding aggressive lymphomas like Burkitt lymphoma, you see any role of, because to me, to my learning, relapsed Burkitt is almost a gone case, so you can't do anything. You see any role of CAR-T or something like that for a relapsed Burkitt? Dr. Ajit, you can take this. For relapsed Burkitt,
Sir, saying Burkitt is such an aggressive B cell malignancy that CAR T cell, using CAR T cell in this group is biologically challenging. One is that it doubles, so its doubling time is so high, and it is such an aggressive disease. I do not think patient will have that time period or the window period for that car manufacturing, or going ahead with the CAR therapy because it will definitely relapse within that period of time. That is one. Secondly, I think there will be a lot of T cell exhaustion, biologically speaking, because the tumor itself has got so much of cell turnover that the CAR product will get exhausted. I think these two factors definitely is going to make production or making CAR option of treatment in Burkitt become very difficult. And another thing is that with the such a high tumor burden, using CAR as a therapy, I'm not very sure how much of toxicity we are dealing with. So there are multiple unanswered questions. One thing that the reports have, some case series that I had seen that it has given to good response, but what is the duration of response is the question.
Yes, right. But it being a very aggressive, I don't think CAR is an easy job. And regarding CNS lymphoma, any experience of a CAR in CNS lymphoma, primary CNS lymphoma?
I have used CAR in one refractory primary CNS lymphomas. Now, one of the reassuring part is they cross the blood-brain barrier, and uh, the patient is for my patient, the patient is doing fine, still in remission, 1.5 year. The patient was 67 year of old, very less toxicity. Uh, Getting him to remission was not difficult. The only, I think, intervention we did was to reduce his tumor burden a little bit before CAR. So, as sir said, the radiotherapy works very well. So, we had pre-CAR, after collection, we had used whole brain RT during that period of time and also some rituximab just to keep the tumor at bay. And by the time the CAR got manufactured and we could infuse, the tumor burden and the size of the tumor reduced significantly after the radiation therapy. And post CAR, the patient did very well. Only the toxicity that we saw was grade 1 to 2 CRS. There were no ICANS related symptoms. Another interesting fact in this patient that we found was that the patient developed some coagulopathy. There was no other parameters which we could uh, blame it on. So one of the I would say occurrence is the car associated coagulopathy. So this was one experience that I had with primary CNS lymphoma.
So, Arijit, your coagulopathy, this was more with Malaysian ones or the Indian ones?
Sir, Malaysian ones. Malaysian ones.
Malaysian ones.
Yeah.
Yes, yes. So, I think it was a good discussion. Dr. Vipul, thank you for making here. I wish you good early recovery. You are sick and you still
Thank you.
doing that.
Thank you very much. Sorry, I'm admitted, so I couldn't contribute
No
much.
issue, no issue. You still joined. It was good. Thank you.
But just
I
one
think we
question.
yes,
Arijit,
yes.
he used a bispecific car. From where did you get the bispecific car? I mean,
So we got it from Malaysia itself. There was a lab called Oxy Labs. So we got it from there. Yeah.
So you
do
enjoy
you have
which
to take
center?
government approval?
Yeah, yeah.
Do you have to take government approval for the same?
Yeah, we had to get a DGCI approval, sir.
And DCGI does give approval if it's.
Yeah, they gave the approval. There are some paperwork involved, but it gets done.
Okay, the whole story of dual car is like this is the problem in the West is so all the trials have stopped because
Yeah.
it has never been more efficacious in a single car,
Yeah.
and each of them compete with each other, and none of the targets have been better than CD19. But
19.
definitely, dual and triple car is a future. But right now, we have not been able to crack the code.
Yeah, I
So
think
it's really
biologically it
hard.
makes more sense, but I think it is yet to we still need to solve the puzzle as to which targets to select. I think at this point of time, the only best target that we have is CD19.
Yeah. So for us, dual cars in Seattle was always reserved for patients who relapsed after CD19. They were never ever upfront. They will never ever move upfront. I mean, not never ever. I mean, they're trying to, but till now it's not very successful. But I hope so because it's definitely the future because then you can prevent antigen escape. Yeah.
Yes. Thank you.
Thank you.
Thank you, team, and thank you, everyone, all the speakers, all panelists, and starting from Dr. Naveen, then Dr. Deves was there, Dr. Aryan Jain had a beautiful topic on AML. Dr. Sima Madam, although there was some technical glitch. All my esteemed panelists also, including Dr. Manoj Mahajan, Dr. Ajay Yadav, Dr. Ashish Verma, Dr. Akshay, Dr. Then Rajan Kapoor, sir, everyone. And Dr. Arjit, special thank you to make this. And Dr. Bhavesh, sir, thank you for being here for last 2.5 hours. And I'm awaiting you tomorrow again, a full day presence, sir. And thank you all our industry partners and all the sponsor and all other attendees who have joined. Some of my residents and staff, they have joined to learn something. Thank you, everyone. And thank you, Team Cancer
Thank you.
Research. Thank you, Pooja.
Thank you,
Thank
Dr.
you, sir.
Prakash. Sorry
Thank you,
for
sir.
not putting
Thanks,
slides, more slides. Just
Thanks,
having
thanks
information.
everybody.
Thank you. Thank
Thank
you
you.
everyone for joining this webinar, and thank you for the good discussions and talks. Thanks to my colleague Pooja and Anjali and the technical team. Thank you everyone. Good night everyone. We'll meet
Excuse
again.
me, ma'am.
Tomorrow we meet again
Ma'am,
at 6:30 p.m. start.
Yeah, share the
हाँ.
video. Pooja, you can run the video.
I will share the video.
Yeah, run. So we have to abide by the compliances. So we need to share the video.
We need to share?
Yeah, we are sharing.
Some protect, some repair, and some defend. And among them are T cells, the guardians of our immune system. Their mission is simple: to identify what doesn't belong and eliminate it. But cancer is different. Cancer has challenged treatment for decades. What if the answer lies within the patient? This is CAR T cell therapy. The process begins with the patient's own T cells. These cells are collected and engineered with a new capability, a specialized receptor that enables them to recognize specific cancer targets. Once transformed, they are expanded into millions of CAR T cells, prepared for a singular purpose: to seek out cancer cells wherever they may be. They engage cancer cells and trigger their destruction. As they continue to expand, more CAR T cells are generated, reinforcing the immune response and strengthening the attack against cancer. Built from living cells, powered immune system, CAR T cell therapy is redefining the future of cancer care.
Thank you. Thank you, sir.